Chairperson can log in anytime. Good morning. Good morning to one and all who joined today for the webinar on World 2021. I would like to welcome Professor HOD Dr. Tagore Madam, the Department of Microbiology, who is jointly hosting this webinar. At the outset, we would like to thank our beloved chairperson, Professor Dr. Mala Madam, for giving us this opportunity to host an important public health day of significance. And all of you are aware that in this college, we are very proactive in undertaking all these activities because we believe that it is important as medical doctors and students in this college to observe these days, commemorate these days, and spread the message to the outside world. So thank you, Madam, for giving us this opportunity. We would like to thank our Dean, Dr. Kumada Lingaraj, who just confirmed us to go ahead with this program and she would join later. And we would like to thank her for constant encouragement and support in promoting these kind of educational and informational activities. We would like to thank our medical superintendent, Dr. Karunanidhi sir, for extending support in undertaking these activities. Once again, the hospital activities are deeply connected with the academic activities. We serve the populations who are coming to our hospitals, linking them through research. Thank you, sir. We would like to submit our sincere thanks and gratitude to our secretary, sir, who constantly encourages us to go beyond all these academic and hospital related things and pursue research. Thank you, sir, for your constant encouragement. Now, the departments of microbiology and community medicine are intertwined when it comes to HIV/AIDS. We all know the importance of World AIDS Day being celebrated or observed or commemorated after 40 years in a city like Chennai. I would like to remember Dr. Suniti Solomon, who was the first microbiologist who actually was pioneer in detecting the first HIV/AIDS case among the high-risk group population in Chennai way back in 1985-86. And because of her research, it was notified that HIV case was detected in Chennai, and the entire world took notice of Chennai in 1980s. Later, our earlier former dean, Dr. Shanta Madam, another microbiologist, was involved in HIV research, and both Dr. Suniti Solomon and Dr. Shanta Madam were instrumental as microbiologists in doing molecular level HIV research. And they are an inspiration for me as a researcher to continue my HIV related research entry. That is the reason I came to Chennai. And some of my students and my colleagues in this college remember that the reason I'm in Chennai is because of my HIV fellowship, which I have completed in 2007-8 with the Hospital of Thoracic Medicine, which is a CDC funded 1-year full-time fellowship, which actually changed my personality as a HIV researcher with the tuberculosis connection. And that is the reason why I repeat, World AIDS Day has an important significance in every researcher's life. Being Indians, we know what is the significance of tuberculosis. Once again, HIV and tuberculosis are considered as twin burdens. And with the advent of Corona pandemic towards the end of 2019, this HIV pandemic has taken a different turn, and the word pandemic itself has revealed multiple dimensions. And in today's context, when we are talking about World AIDS Day in 2021, the pandemic has taken a different twist in the sense like the inequalities. The theme of World AIDS 2021 is End Inequalities, End HIV/AIDS. So in today's context, the world is looking at HIV/AIDS corona pandemic in 2021 towards December, and we are looking towards the future how we can address these two pandemics. And today's webinar being hosted by Department of Community Medicine and jointly with Department of Microbiology are bringing to your attention with multiple experts from YRG Care, Chettinadu Research and Medical Hospital, and Sri Venkateswara Medical College and Research Center from Pondicherry, along with NGOs like Born to Win, the NGO which is serving LGBTQ community, and the program managers who are working with NACO, National AIDS Control Organization programs in South India. They are going to share various insights how the HIV epidemic is being tackled and how COVID-19 pandemic has actually exposed the inequalities, how it pushed back the decades of efforts to contain HIV pandemic and expose the underbelly of HIV inequalities once again to the forefront. All these issues will be discussed in this live webinar, and I'm extremely happy to share with you the support extended by the management, the administration, my colleagues in the Department of Microbiology, especially Dr. Tenmoli Vali Madam, my guide and mentor, Dr. Kannan Sir, my own department, Dr. Shivagurunathan, Dr. Karthik, Dr. Vikram, my youngest faculties, Dr. Avinash, and my entire brigade of postgraduates, Dr. Vinod Raja, Dr. Kirtana, Dr. Kavita, Dr. Niveda, and my interns who recently joined the department for 2 months. I thank everyone at the outset itself because the routine is to thank them towards the end, but I would like to submit my thanks to everyone at the outset at the inaugural ceremony. This day is of extreme importance, and through this webinar, we want all of your support towards ending the inequalities and ending this HIV/AIDS epidemic, because the target set was 2030. Unfortunately, because of the pandemic, which came towards the beginning of 2020, the inequalities have been exposed once again, expanded once again, and it is our utmost responsibility to address them. And this webinar is going to open the windows of opportunity for us to address these inequalities. And this webinar is going to help us understand where are those opportunities. And my interns, the next generation of doctors, the leaders in the field, and the experts in the academic world, like medical colleges, in the hospitals, are there to think through this problem and address it head on. With this few words, I would now like to request Dr. Kannan sir to screen the video, which is the message from WHO Director General on the eve of World AIDS Day 2021. Sir, I request you to screen the video. Thank you so much.
Nearly 2 years into the COVID-19 pandemic, we're still a long way from ending it. But there is another infectious threat that, after more than 40 years, is not over either: the HIV/AIDS epidemic. Around the world, almost 38 million people live with HIV. Last year, an estimated 1.5 million people were newly infected, and 680,000 people died from causes related to AIDS. While some countries have made real progress against the disease, many others are falling behind. Even before the COVID-19 pandemic hit, many of the most at-risk populations were not being reached with HIV testing, prevention, and care services. The pandemic has made things worse, with the disruption of essential health services and the increased vulnerability of people with HIV to COVID-19. Like COVID-19, we have all the tools to end the AIDS epidemic if we use them well. On World AIDS 2021, WHO calls on governments and citizens to use every tool in the toolbox to narrow inequalities, prevent HIV infections, save lives, and end the AIDS epidemic.
The WHO director's message is very crisp. He addresses that even before the arrival of the pandemic, we are falling behind reaching the targets. If you look at the target set, as I reminded you in my opening remarks, we set the target that by 2030, we have to reverse the epidemic of HIV/AIDS. Unfortunately, as it was highlighted in the message, even before the arrival of the pandemic, certain number of countries are unable to reach this milestone. Though there are tools available in the toolkit, certain countries are unable to reach these milestones. So during the next scheduled event of the plenary session, we have experts to address these points, and we are definitely going to deliberate on these points. Why certain countries are not making the progress? What are the structural inequalities across the countries in the world which make them unable to reach these milestones? And we have diverse specialists, microbiologists, community health experts, and also a person like me who worked in HIV program before I joined academia. And it's almost 10 years now I'm in this college. So we will be blending all our experiences and share the insights during the moderated panel discussion. Before that, I would also request all our audience participants comprising medical students, interns, doctors, and development sector specialists who joined in the Zoom panel as well as Zoom rooms and YouTube channels, how we are going to address this problem in the next decade so that by 2030, we will be able to channelize our efforts and address this pandemic head on. So before I go on to start the moderated plenary panel titled Reach People Left Behind, Looking Through the Lens of Inequalities, I would like to introduce the esteemed panel. I'm starting with Dr. Kumudha Lingaraj. I'm told that Madam is doing grand rounds in the hospital and she will be able to join. But I would like to introduce to the group Dr. Kumudha Lingaraj, Dean of Tagore Medical College Hospital. Is a specialist in anesthesia. She was heading the Department of Anesthesia in Tagore Medical College. Earlier, she was the Dean of Thanjavur Medical College. Her illustrious career spans over 3+ decades. Madam has been instrumental in bringing systemic and infrastructural changes in Thanjavur Medical College. Before her, again, another illustrious milestone in Thanjavur during the festivals of Thanjavur. And she joined Tagore family a year back, and we are extremely honored by her presence. Personally, I believe in women leadership, and our institution is led by our beloved professor, Dr. Mala Madam, our beloved chairperson. And now again, Shanta Madam was our former dean, and we also now have another woman leader as dean of our institution. We invite her. We hope that she will join the plenary panel very soon, completing her grand rounds. Thank you so much, Madam, for being part of our panel. The other woman leader heading the department of our microbiology is Dr. Tenmoli Valli Madam. Is Madam here? Can you just request Madam to join the panel? Dr. Tenmoli Valli Madam is the head of the Department of Microbiology. Again, I'm blessed to work with Madam for a long period of time. Madam is also the Director of Allied Health Services Sciences. As I always believe, women leaders do multitasking, and Madam is heading the Director of Allied Health Services courses in Tagore Group of Institutions. She's also the Professor HOD of Microbiology Department. And as we have a long working relationship, we share multiple common interests. And I hope Madam will be joining very soon. We welcome you, Madam, for today's plenary panel session. We also have with us our esteemed colleague, another woman emerging leader, Dr. Suganya. She is with us, very much in waiting wings.
Hello, ma'am.
Very happy to see you.
Same here, ma'am. Very happy.
Yeah. Dr. Suganya is currently working as assistant professor in the Department of Community Medicine at Sri Venkateshwara Medical College Hospital and Research Center at Puducherry. Earlier, she was working with us in Tagore Medical College. She is a very active, dynamic, young faculty. We used to do a lot of research work together, and she's the most beloved teacher of the students, most student-friendly teacher. And these are all the characteristics which uniquely identify an emerging leader, again, another woman leader in the making. And we are very happy to welcome you for today's plenary session, Dr. Suganya. Thank you for accepting our invitation.
Thank you, ma'am. Thank you for inviting.
And again, it is now my greatest pleasure to invite my friend for a long time, Dr. Arvind Manoharan. Dr. Arvind, are you there?
Yeah, ma'am. Can you hear me? Good morning.
Yes, yes. Thank you so much. Again, Dr. Arvind is a long-time friend for me. Currently, Dr. Arvind is Associate Professor, Community Medicine at Chettinadu College and Research Institute. Dr. Arvind is also a very illustrious researcher. His research in rabies has been published in World Health Organization, technical expert, weekly epidemiological reports and all that. He's a calm person by nature, but deeply intellectual, and he guides postgraduate students in Chettinadu, and he's almost like a single man rock star kind of person who takes care of centers in Chettinadu, the rural urban centers, trains interns, and as you know, Chettinadu has 250 strength of undergraduate students. So a person's strength is not like the kind of nature, but the deep strength he has, and his research is deeply appreciated up to the level of WHO, and he's been a strong support to me when I was going through my own personal crisis and mental health issues. He's been a staunch mental anchor for me. He literally pulled me out of my crisis at one point of life, and I'm thankful for him. Thank you so much for accepting this invitation, Dr. Arvind. And yes, and Dr. Tenmoli Valley, madam, have you been linked to us in the link, madam?
I'm always there. Thank you so much for your kind words.
Yes, madam. Yes, madam. Thank you for accepting our invitation to conduct this program jointly, because microbiology is one of the departments which is leading worldwide research in HIV, and we are extremely happy to have you here. And thank you so much for being a guiding light for us in conducting this program, and helping us to host this program and being part of this. We need elderly support and guidance from senior leaders like you. Thank you so much, madam.
Thank you so much.
Yes, madam. With your permission, we would like to start our moderated panel. Is it okay, madam? Shall we start our panel? Do we start, madam? Yes, ma'am. So I welcome all the panelists for today's plenary panel. Once again, I would like to ask her to mute everyone. So once again, I would like to welcome all the participants for today's plenary panel. The title is Reaching People Left Behind. So there is some audio disturbance, so thankfully it was muted. So the plenary panel is titled Reaching People Left Behind and Looking Through the Lens of Inequalities. As all of us are aware, the World AIDS Day 2021 theme is Ending Inequalities, Thereby Ending AIDS. So I would like to start with Dr. Tenmoli Valli, Madam. Madam, as the senior most microbiologist, especially the specialist in this field of HIV/AIDS for long, what are your insights regarding this field, Madam?
First of all, I would like to thank you for including me in this. It gives me an immense pleasure and honor to be part of this program. World AIDS Day 2021 with the theme Ending Inequalities and AIDS. As you said, it's a special focus on reaching people left for behind and to reach the people who are not receiving essential treatments and neglected group of people. So you told me that I am the senior faculty of this. I would like to share certain important progress what we saw during our professional career. Because I did my PG from 1983 to 86. During that period only the HIV newly introduced into health sector. It was a new one when we were doing our post-graduation. And slowly all the research work has been carried out, and we used to study only half page of AIDS those days. Now you see volumes and volumes of books are there. Actually one of the disease which is given utmost importance, I feel, the VIP disease. I always think as the VIP disease that it has gained a lot of importance, but still, as our WHO sir told, that it's still a major public health issue, even after losing 36 million lives so far. So, what finally, where we are is, even though we don't have the cure for this, we have a patient living with a chronic disease. That itself is a big milestone in this particular disease. Enabling people to live. When it came during 83, 80 and all, everybody used to be scared of this disease. But now they take it a little bit, I won't say that they were taking it casually, but the scare has come down definitely. So the condition, they are accepting and living with HIV infection and AIDS. So as predicted, every year there are about 6 million people, 1.5 to 2 million people are added, newly infected, and with a global proposed target of 95, 95, 95. I think all of you must be knowing that 95% of diagnostic. Among the diagnosis, we have to at least cover 95% of population with infected population with antiviral therapy, and 95% of the antiviral therapy has to have a virally suppressed state. With this thing and with a lot of research still going on and drug resistance and vaccines and all that, it is unfortunate that we are still struggling to get a vaccine, successful vaccine for this. I think Moderna is trying out messenger RNA vaccine, that is 1644 and 1644V2. Still it is in the clinical trial. With all this background, today's theme, we'll come to the today's theme, that is inequality, to end the inequality, to end AIDS. The inequality is existing everywhere, like gender inequality, social inequality, economic inequality. So the stigma and discrimination is one of the important things what the society has to eradicate among them. So we have to consider them also as our fellow human being and make them. And with all this background, if you see the literature, it doesn't lie with the government alone. We have to take a complete measure, in the sense government and the society also to be to share the responsibility of this, and we have to have the awareness even more effectively. And the social determinants play an important role in predicting the HIV outcome. That is the thing where they are born and they are grown, living and work and so on and so forth. So all these things has to be the bridge between the neglected population has to be taken care of. Health services, economic, and they say the health outcome is the mirror of inequality in the broader society. So the inequality existing, we must that is the problem and it is a burning situation and current situation where we are having so much of inequality in our society. So all that the strong law and enforcement, which is already there, but it has to be put into use effectively to take away the discrimination among the society, has to be done by the government and globally. And it is still this thing I could find that so much of awareness and all that, the HIV testing across the countries, about 30 countries, it fell by 41% in recent past years. So if we are having a target, we have to have that effectively going. So say for example, allotting fund for HIV testing, we were talking about the testing, antiviral therapy and viral suppression as a target for achieving this goal. But we are going to reduce the budget or the funds. I don't know, I really, it is a surprise or it is really a question that how we are going to achieve this, and the target of 2030 also. Thank you so much.
Yeah. Thank you, madam.
You want me to add or questions on this?
Yes, we'll come back in the second round of discussion to go into, but you have highlighted the most important point. I will connect one or two points from your insights to the next speaker. Dr. Arvind, madam has correctly identified social determinants of health which are leading to certain inequalities in vulnerable population. Can you just share what are your thoughts about how these social determinants of health are leading to inequalities?
First of all, I want to re-emphasize what Madam has told, that definitely the social inequalities is there. Even during COVID pandemic, what happened was there was a strict complete lockdown throughout the world. What happened, even in India, those who are having own transportation, they were able to get some passes and go and get their treatment for various diseases. Okay, the same way with respect to ART, the ART centers almost were closed and they don't know how to function. So because of which the underprivileged population suffered the most. Okay, so that is how we can compare this with the social inequalities. And also we have to take this with respect to social determinants. Okay, not alone the inequalities, other determinants such as homelessness and poor income, loss of job. So all those can also be compared, and this also play a vital role in the management. Okay, so the governments didn't have clues how to run the centers, not with respect to ART alone. we can compare to general health checkups and also immunization services, which is very essential for prevention of communicable diseases. So all those things has been hampered. So it can be viewed in point of social determinants as well. That is my point.
Thank you. But coming back to your own contribution to the panel topic, when we talk about ending inequalities by 2030, highlighting the World AIDS Day, what are your thoughts?
I'm not getting your question. I think there is some disturbance.
Okay, I'll repeat it. The World AIDS Day 2021 theme is ending inequalities, thereby ending HIV/AIDS.
Right.
As a panelist, how can we address this through the lens of inequalities? How we can focus this approach and end the HIV/AIDS?
See, that should be through the policies, the government policies, and how the government would like to take it further. So the very aim of the primary health care, which is core of any management or control program, is ending inequalities. One of the principal behind is there should be equitable distribution. So that is how we can take through.
Yeah.
If you follow the primary health care principles, definitely we can overcome these things.
Great. So being a primary healthcare physicians, we have to keep on applying this primary healthcare approach and equitable distribution kind of framework towards the HIV/AIDS pandemic also, so that we can bridge these gaps and try to counter the inequalities to further spread and also to narrow the gaps. Thank you.
And one thing which I want to tell is during this pandemic, most of the people were clueless, including the government. So the backbone of any preventive or control program, that is primary healthcare, has hampered. So that is the reason why people suffered for each and every health condition, even for COVID-19.
Okay. Thank you so much for highlighting repeatedly how the cluelessness was highlighted during the emergence of the pandemic. Now I would like to reach out to the panelist, Dr. Suganya. When you hear this kind of input being shared by the co-panelists, now, Dr. Suganya, how would you like to offer the solutions? How can we reach out to the people when the government itself is clueless?
This time, the towards addressing the inequalities. So as of what the panelists have already described, why it is important, I just want to make one thing very clear. So there were a lot of advancement right from the identification of when is AIDS was the first case of AIDS. So now we are at a level where we have a lot of diagnostic facilities, we have a lot of treatment facilities, and there are a lot of policies which is for the control and prevention of AIDS. But still we are lacking. The main reason is that, so what is that? Whatever we need is already there. So now the distribution is the only thing which is affected. So that is the main scope where the inequality, as you all said, like this is the reason. So for addressing this issue, one thing what we have to do is, as of any disease, what we concentrate, we have to target the high risk population. As of AIDS, we have certain key populations. So like, for example, IV drug abusers, sex workers and homosexuals and truck drivers. And so we have so many group of people who are potent for a highly, they form a high risk groups. And most importantly, this resources is distributed unequally. So though it is also available for them, so it is like just give and take phenomenon, and they are not assessed regarding what is their difficulty. And last year we had a theme, like maybe 2 years back, we had a theme mainly towards the mandatory HIV testing. When that was imposed, there was a lot of people who were against that when it was a mandatory HIV testing. So our scheme should be in such a way that right from the policy making, whom we are going to, even when we make a questionnaire, no, like to whom involved in framing that will be more effective. So if it is a national policy, then the persons who are going to get involved, the persons who are going to get benefited, they should be also the part of policy making, and they should all their flaws or all their difficulties to get the policy accepted and all the measures what they face it as a hindrance to get it done, or accessibility issues, everything has to be first enlisted. Then when they do an appropriate policy making, and before the implementation of the policy, in all the stages, right from the idea generation, from every stages, if one member is definitely from the community which is affected is getting involved, even from the data collection everywhere. So when there is a member involved in every stages of this policy implementation, I think this inequality, though it cannot be completely stopped immediately, because this has been for 40 years and definitely takes some time, but involving them will maybe hasten the process of controlling the inequality and thereby ending the AIDS.
Wonderful. It is very much important that you have brought our attention to the high-risk group population, as Dr. Thenmozhi Valli Madam also highlighted, especially the social determinants of health contributing to inequalities, and vulnerable population, high-risk group population, they require special focus. And Dr. Arvind highlighted the policy attentions, because the top level leaders, unless they take proactive measures, we cannot implement these measures at the grassroots level. Now, coming back to Dr. Thenmozhi Valli Madam, how can leaders be more proactive when we talk about addressing inequalities? What are your suggestions? Because you have been in that leadership position as a dean, as a director for a long time. As a leader, what kind of approaches you would recommend them?
We have to identify the problem in that particular area. Why we are not able to achieve. So identifying the problem for not achieving the goal has to be sorted it out. And a clear protocol has to be designed for overcoming the problems. I think that lies with the vision of the leader of that particular program or area or whoever it is. So that is very important. Identifying the problem at the root level and designing the measures to overcome the problems. And I think as far as HIV is concerned, we have done a lot of, we have achieved many targets. I think with the same momentum, the government will achieve this also. That is the inequality and to end AIDS. To end the inequality, to end the AIDS. So it all depends on how the, say for example, it is very well as said by the WHO, it is not uniform among the countries also. Some of the countries are neglected. It's like that. How a country takes that problem, how effectively it executes. As far as India is concerned, all the health programs are very well. Say for example, vaccination program, pulse polio vaccination. So it is not, as far as our country is concerned, they are taking good measures. But then, as far as HIV is concerned, we see in recent years the allotment for budget allotment for HIV has come down. So, to achieve this goal, the making policy and fund, without fund, it's very difficult to do achieve any target at all. So that has to be, the government has to see to that it keeps going. The allotment of fund and people, and it is not a disease where you can identify the disease and give some medicine and handle with that. You have to have counselors. You have to, so many paramedical people are involved in that. So all that has to be strengthened, and the assurance and all that given to them. I just remember when Dr. Suganya spoke about, she was telling about the mandatory test. When I was working in a private lab in 80s, they said, I told them, I suggested them for testing pregnant women, antenatal testing. Those days back. After that only it became mandatory. But gynecologists refused to do that because it was not a vision that we are taught. Now it has become mandatory. So like that, it keeps changing. We have to, as it requires, for the need of the hour, what is needed for that particular hour has to be taken care of. And this thing, testing for everything, testing is the base. Even for COVID-19, it is testing. First comes the testing, and then rest of the things. But, as I mentioned already, it fell by 41%, the testing in some of the countries, so that they have to take care of. So I would like to mention here that they are suspecting Omicron is from HIV. Suspecting, it's not proved. With all this, I think we are having good population of HIV also. So once Omicron comes, they say the prolonged survival of the virus in that HIV individual, they can become more prone for mutation. So like that, we are also at the high risk of this Omicron arrival to India. So they have to take care. They take care of the what challenges they are facing.
Thank you, madam. That was a real, very elaborative insights, because you have been a leader. We are able to understand how a leader has to approach this, and you're starting inside when you say like we have to analyze why we could not achieve the goals. That is a real pragmatic approach, because we are setting goals for every program, like we have to end this by this timeline, and if you are unable to reach that, as a leader you have to sit down with the team, or you have to analyze what are the reasons, what are the factors, what are the situations which did not allow us to reach that, and we have to do the mid-course correction. That was a real very wonderful practical application which we can also apply immediately. Now let me come back to Dr. Suganya once again. Madam has said that we need to look back to the policies and see what is the need of the hour. And today's topic is addressing the inequalities and reaching the vulnerable population. Dr. Suganya, as a community researchers, I know personally, we are involved with some research in HIV/AIDS. So can you share any of your HIV-related research experiences trying to address these inequalities in vulnerable population?
Regarding the research experience, first, though there has been a lot of awareness program given, there are still population who are confused about the modes of transmission. And what every one of us are clear now to this extent is that HIV is a sexually transmitted disease. They are aware of that. That is a good change from comparing to the previous decades. But still, there are so many modes of transmission like placental and all this and all. Like there are so many misconceptions about that. So when we want to inequalities, we are not talking only in terms of accessibility issues or accessibility, or whether there is going to be a gender inequality and all. Even this awareness level, why there is a big knowledge gap when it is from one place to another. So how are we going to address that? Is that only the education which is making them not aware of that, or we concentrating all our resources towards one particular area? So as these are all the major problems, and what we, as you are telling, like regarding the high risk groups and all, what we could do. So there was a lot of previously there were a lot of legalization issues for sex workers, and there were so many laws against that. So this present strategic plan, the main concept or main element of this present strategic plan is that they are making the legalizations enabled. So it has to be like, it should not be punishable more. It should not be more of punishable rather than it has to be in a sense of acceptable. So though it is a bit inconvenient for this time to accept the fact that sex working should be not be a legalized issue. So what could be so it is not like it should not be a punishable issue, I mean. So once we make things in a straight line or transparent, once we make that it is not going to be punishable, we can frame some system. Like in case if there is going to be this type of work, which any type of occupation which increase probability of HIV. So we could just list out those occupation or high risk groups and make them register. So once we do that, we will be having the line listing of the patients or participants or marginalized groups who are being involved in this transmission of the infection. We could have a constant track of those persons. So we could also have the proper testing of that person. So when we make the things as like a highly punishable, people will hide themselves from exposing on what occupation they are. And this disease being of more of sexually transmitted, and all this is being in this hidden sense. So we cannot stop the epidemic or pandemic of AIDS at any point of time. So this strategic plan, the main aim, one of the component of the strategic plan is to decrease to make the things legalization in an enable manner more than that of the punishable manner. This is not only for the sex workers. There are a lot of difficulties in the right issues for the transgenders, homosexuals, who are also one of the important sources of transmission. They serve as an important persons for transmitting the infection. The main reason is that they are not getting accessibility, they are not getting the acceptance, and they are constantly discriminated in every part, whether it is going to be the medical services or whether it is getting involved with the other people. So when the things are, so we cannot blame that. You're just telling that they are going to be the high risk groups. Only this inclusion and the law substitution and involving the community themselves in this could, I feel like, could help in training all the sense of an AIDS pandemic actually.
That is really a helpful learning for us in this panel, because you are aware that I do work with LGBTQ community for my tobacco harm reduction research. And in one of our currently being analyzed paper, we found that 49% of our research population, like we have a data of around 1,000. And when we are analyzing that, we found that 49% of them are earning their livelihood through commercial sex activity. Okay, so when almost half of the studied population of LGBTQ spectrum, the main occupation for their livelihood is commercial sex activity. And as you have currently shared, if you are not enabling that occupation from decriminalization, and if they are prone to indulge in that high-risk behavior without that criminalization label, and if they are considering that as a high-risk behavior and hiding and not practicing safe sexual practices, as you said, there is a constant nature of epidemic continuously spreading, or there is a risk of the transmission of HIV infection. Thank you for highlighting this entire dynamics of transmission and how it can continue the epidemic without putting an end to it. Now, I would like to bring in Dr. Arvind, and I would like to ask him what other vulnerable populations other than commercial sexual activity related populations are being neglected in the pandemic scenario. Dr. Arvind, can you share your thoughts being a public health scientist?
Yeah, actually, other than that, as everyone knows, the men who is having sex with men, the homosexuals, and IV drug abusers, these populations are also being neglected. So now there are strict laws against using drugs, but still we are getting source of these things, and the IV drug abusers are still there in our country. So these two entities has also be kept in mind when you are considering about the vulnerable population. And also people who are with autoimmune disorders, and these people also are important, because if they develop HIV/AIDS, the problems which they will face will be more, and the ART treatments might also not be effective as compared to the other people.
Wonderful. Definitely, as you said, like the other two groups which are also to be in the loop of consideration includes IV drug users, and especially the IV drug using is becoming a pandemic proportion too, especially with Punjab being the epicenter of intravenous drug use in the country. And as we are all knowing, that is the problem is brewing in the country, though it is banned for various narcotic laws. as we know that it's not just IV drug users who are at the risk of HIV transmission, their sexual partners, they are also at risk. And as we know, these two groups become vulnerable population. And when we talk about inequalities, we need to focus our spotlight on the users and their intimate partners. And that is one focus we have to, again, as part of our webinar discussion, we should include them in the vulnerable population. Now, coming back to the last round of our panel discussion, to summarize our thoughts, going forward in the next decade, going to address these inequalities and coming to the conclusion that by 2030, we will be able to end HIV/AIDS to be a public health problem of significance in a country like India. And Madam has highlighted that a significant amount of attention has been given in the 4 decades, but still millions of populations are being affected and infected by the HIV infection still today. And as we discussed, and also the WHO director has highlighted, the pandemic has brought to our attention that we have fallen behind because of various factors. And Dr. Arvind also has highlighted policymakers were trying to address the pandemic and they neglected certain other health issues, including HIV. So going forward in our conclusion round, I would like to invite all the panelists, starting with Dr. Tenmoli Valley Madam. Madam, what are your concluding thoughts as medical fraternity? How can we go forward in the next decade, re-emphasizing our commitment to end the HIV/AIDS pandemic?
I think we are almost we are in the journey of 3/4. That we have to have a specific target, in the sense, what I feel is awareness or kind of social reforms has to be taken in the society. It should start with the society also. So we have to accept people. See, when the individual is suffering from syphilis, we don't put any scar on the patient. We accept that as one of the sexually transmitted disease and take treatment and get cured, and your life will be going on. But when the person gets infected with HIV, there is a kind of untouchability there. And here we have to thank our late little princess Diana. That we have to remember that, because she only shook her hand with the HIV patient and showed that handshaking is not going to transmit the disease. Like that, we'll have to create a lot of awareness, and the people like celebrities like Kala made a very good impact on the society, and we have to consider the HIV infected individuals, and they should not discriminate them. Discrimination is one of the things which has to be eliminated from the society, whether it is health-wise or otherwise. Any kind of discrimination should not be existing. So that I feel it starts with the society, and that aspect also has to be taken care of.
Thank you, Madam. That was a wonderful message. Accepting and not accepting and discrimination is the message. Dr. What is your concluding statement towards addressing this pandemic and ending the inequalities?
As ma'am said, first we have to overcome the discrimination what is already prevailing. That is the most important thing. Then only we could include them. And as I told before, like for this pandemic or to overcome the inequalities to end this, we have to involve the high-risk groups. We have to involve the high-risk groups in the policy making, implementation, even for the data collection purpose. And we have to also given hands for the healthcare workers, because during this pandemic situation, they are all towards, there is already, it is a well-known fact that the doctor population ratio is very less in our country. And in such a COVID pandemic situation, all of them are moved towards a single disease, leaving a complete bulk of disease, which is itself is a silent pandemic actually. So for such purposes, often there is an issues with the proper handling of the manpower. Like most of the problems, like all the works are not at the level of doctors or nurses, which have to be done. There was 40% of the work can be done by even any person with a minimal training, like for dispensing the drugs. For those who are also when handled by this persons who are already in less number. So the task force has to be implemented, like from the community. They have to be trained and they have to give a support manpower for the system, so make things more acceptable. And it has to be transparent. Whatever the policies, first everyone should know that. So policies are written in guidelines and pages, so it has to be publicized actually. So that is the only important thing. When only people should, the transgenders are already, like, I'm not talking only about the trans, anyone who are having a great stigmatization or being discriminated, they are not aware of what policy they have. Even we are not, most of them, aware of what, there are a lot of national programs, we are not aware of the policy. If this is the situation for a public health expert and the person who are educated to this level, what could be the expectation of those people who are completely neglected right from their child? So in that case, it is the responsibility of the government to propaganda. Even it is okay to more than publicization, even if it is any sort of publicization, it could be propaganda, IECs, in mass media. We are having lot of there. You can see that during the politics, like whenever the election was there were a lot of ads for them. So we could impart a small time, less time daily, for what are all the policies which is available, so that it could be properly utilized by the persons actually.
Wonderful. That is a real kind of conclusion for this entire webinar. When you say, like, it is not just about information, education, communication, and behavior change communication, it's also about policy communication to the beneficiaries and also to the experts, so that we know what kind of policies are being made at the top level, and we can be transparent about the changes, whether they are reflecting the needs of the communities. Thank you so much for that beautiful insight. Now, finally, I would like to call upon Dr. Arvind. What is your concluding take forward message for the next decade to end the inequalities and put an end to the HIV/AIDS pandemic being a public health problem anymore in India?
Yeah. To add on to Dr. Suganya, she has spoken about the healthcare providers, workers, and all. And I think from the point of view of infrastructure, health infrastructure. Okay, so you have heard about TB hospitals, leprosy hospitals. Have you heard about any HIV hospitals? So that's the thing. So the other countries, developed countries, they are trying to build a special infrastructure for HIV patients alone. Okay, so and considering this pandemic, we should think about the multi-month supply for the HIV patients. So going forward, we should have adequate stocks of these medications. And next is the mental health support. As you know, that mental health is poorly conceived and perceived in whole of India. We should make them stronger using the mental health support, and also there should be separate healthcare workers, providers for HIV treatment and management, and also for the supplies, to provide the supplies. Because as we know, in India we are using multi-purpose workers who works for different programs, and when pandemic such as COVID comes in, what happens? All are pulled towards this particular pandemic, ignoring the current the problem, maybe HIV or other diseases. So that is how I think we can have focused individuals who can work towards HIV.
Wonderful.
Yeah.
So Dr. Arvind's forward approaches are like dedicated infrastructure upliftment to focus on HIV/AIDS care delivery, so that along with targeted intervention, he also wants support for mental health component, so that it can also help these HIV infected and affected families to cope with the pandemic, and also with the twin pandemics of HIV and COVID, because I definitely agree COVID has unleashed a lot of mental uncertainty. Even healthcare providers like us, we were going through a lot of uncertainties and trauma, especially emotional uncertainties, what is going to happen with the pandemic and all that. And the HIV infected and affected families can definitely use that component and support services through counseling and all. So to come back to our theme and conclude the plenary panel discussion for today, we through our small efforts in this webinar, we tried to have a discussion on reaching people left behind, and we tried to focus the lens of inequalities. And I would like to summarize the senior Professor HOD Madam Dr. Tenmoli Valli has summarized her entire experience through her student postgraduate days. Was the time when she came to know that the first case was identified in Chennai. And through her career as a leader, as a head of the institution, she has seen how the pandemic has been addressed in India. And as a leader, she has delivered her insights, how we have to analyze the problem when we could not reach our goals or targets. And she also said that accepting the HIV infected as any infectious disease and not accepting stigma and discrimination meted out to HIV infected people is her message. And she quoted Princess Diana: shaking hands has shifted the mindset globally about stigma and discrimination on HIV. Taking this message forward, that is the message I would like to carry forward. To end inequalities, we have to address stigma and discrimination. No more acceptance of stigma and discrimination. No more acceptance of inequalities meted out to vulnerable population. Thank you so much, madam, for that inspiring message. Now, coming to the youngest in this panel, Dr. Suganya, her thoughts about policy interventions, the transparency in drafting policies, policy communication to the beneficiaries, policymakers, scientists, experts, academicians is extremely important. And she highlighted in the pandemic times, whenever we call someone, immediately the vaccine message is coming, preventive messages are coming. Similarly, the policymakers can also think of a creative way. Any policy is being drafted, they can communicate to the population what that policy is about. Thank you so much, Dr. Suganya, for drawing again our attention how we can end inequalities, target high-risk group population. Thank you so much. Coming back to Dr. Arvind, as a policy maker implementing a lot of policies at administration level in Chettinadu, he's speaking like a true policy maker. Uplift the infrastructure. It is not just people at the beneficiary level and implementers. You have to provide the matching infrastructure to deliver quality care. Improve the components of quality care. Provide components of mental care support. Improve the infrastructure to match the care, open dedicated services so that the people will benefit from that quality of care, thereby inequalities will definitely come down. Thank you so much for your wonderful insights. This plenary panel targeting the people who are left behind. With these insights, whoever is attending our webinar will get ample insights how we can go forward in the next decade. And by 2030, I'm very hopeful my medical students, my interns, my co-faculty, and other people, whoever has joined today's webinar hosted by Tagore Medical College and Hospital, jointly by Department of Community Medicine and Microbiology, along with the experts from YRG Care, Venkateshwara Medical College, Puducherry, and Chettinad Research Institute and Medical College, Chennai. This message will reach far and wide. It is hosted on YouTube, and it is, thankfully, we have all the internet support without any disruptions. I thank all the panelists today once again for your great insights and valuable support to make this event a memorable event. I thank you all once again.
Thank you, ma'am. Thank you.
Thank you so much.
Thank you, Dr. Singh.
So the next session will start after a 15-minute break at 10:45. Thank you so much. So welcome back. So after a small okay. I request Dr. Suganya to stop sharing for now because yeah.
Yeah, 1 second, ma'am.
No problem. Yeah. Thank you so much. So welcome back once again to the live webinar of World AIDS Day 2021 at Tagore Medical College and Hospital. This webinar is jointly organized by Department of Community Medicine and Microbiology. The next session, we are going to have our speaker, Dr. Suganya. She's going to talk about Global AIDS Strategy 2021 and 2026. As introduced earlier, Dr. Suganya is currently Assistant Professor at Department of Community Medicine, Sri Venkateshwara Medical College Hospital and Research Center, Puducherry. I'll give a very brief introduction about her resume. She's a MD Community Medicine Gold Medalist from Sri Venkateshwara Medical College, Puducherry. She obtained her MD degree in the year 2017. And she also obtained her MBBS degree from the same institute in 2012. She completed her certificate course in evidence-based diabetes management from PHFI. She has a cumulative work experience after that. She also had, as I mentioned earlier, worked in Tagore Medical College and Hospital. She had various positions while she was at our institution, executive committee member in MCI cell. She was also a part of anti-ragging committee member, and she was also the department in charge. And she had numerous publications to her name and credit. Especially, I'll read very few where we co-authored. We did many in medical leadership, especially interns' perception on leadership skills. Along with Shirley, she has also published effects of video games on socio-behavioral environment. And she also helped a lot of other researchers in Tagore Institution in her publications. She was co-author in many of her publications. She herself presented many conference presentations in both national and international. I'll read out a few of her presentations during the conferences, especially oral presentation titled, "Is Anganwadi Hot Cooked Food Better Than Ready to Eat Mixture?" It was presented in 2015. Again, she presented a poster presentation on gender preferences, reasons and solutions suggested by adolescent girls. It was presented in Mysore International Conference. And she also presented a presentation titled Ethical Dilemmas Among Primary Contacts in Undertaking COVID-19 Testing. It was recently presented in First National Ethical Summit in Palimalar Medical College in the year 2020. And she has achieved many awards and rewards. Mother Teresa Award by an NGO from Sevalayam Palliative Care. Best Paper Award presentation in 2015 for that Anganwadi paper. And external monitor for intensive pulse polio immunization. I remember her receiving IJ Rula Award also. She's the youngest in our department to receive that particular award. And she also received Special Jury Award for poster presentation in a competition with Vibes 2020 for the same paper in Panimalar College. And she also completed a lot of training courses and workshops. She was trained in biomedical waste management, epidemic investigation. She's an RNTCP level, state level observer. And she was trained in qualitative research methodology, data analysis, epidemiological study designs. Her areas of interest include operational research, biostatistics, epidemiological study designs, program evaluations. We welcome you wholeheartedly for this AIDS webinar, Dr. Suganya, and we hope that your session will benefit our audience, especially our young participants. I will not take any more time. Please proceed. Thank you so much.
Thank you so much for inviting me, ma'am. Actually, I feel more privileged because that is the place where I first worked, and it's good to see you all. And if it is going to be the undergraduate, this is the last batch I have taken classes for them. So it's sort of a good field that to take, and all the department faculties are also there. So thank you so much. It means a lot. Thank you.
You can share your screen.
Ma'am, the screen shade, is it visible?
Yes, ma, it is visible.
Okay. Good morning, all. Good to meet you all. So today we are going to discuss about, I'm going to talk about Global AIDS Strategic Plan 2021-2026. Myself, Dr. Suganya Aravind, Assistant Professor working in Venkateshwara Medical College from Department of Community Medicine. So most of the strategic plan strategies were actually discussed in, if you have listened the previous panel discussion. So let's go into that. I think so there is some audio disturbance. Yeah, thank you. 1 second. So coming on to this global strategic plan, I'm so sorry. Just give me a minute. I'll minimize this. Yes. So this new global AIDS strategic plan from 2021 to 2026, as it is emphasized very frequently that to end inequalities and end AIDS, this is going to be a bold approach that is using the inequality. Generally, we used to find out what is the measures which have been taken, what is the progress of the policies which have been implemented. But this strategy is mainly concentrating towards the inequalities. So it's this inequality lens per se. The meaning is that its aim is to first address the inequality so as to prevent the gaps which is required to end the AIDS pandemic. So for regarding this, at Geneva, there had been a meeting by UNAIDS program. So which felt that this strategic plan makes sure that by the end of 2030, AIDS should never be a public health threat to the community. So every community, every country had to take account on that and should follow the strategic plan so that by 2030, this AIDS is never going to be a public health threat. So why should we end inequalities? This is because of the various experiences what we have gained, various steps what we have achieved. So since the first case, which have been reported 40 years back, AIDS is still threatening the world. So today, the world is off track from delivering on the shared commitment. So this is not because we don't have the knowledge about the disease. It's not because we don't have the diagnostic facilities. It's not because whether we don't have the antiretroviral treatment. Yes, we have everything. But there is an inequality, not only in the distribution towards the participants, but it's not only regarding the receiver side, even from the implementation side, there is to whom it has to be given. Why it has to be given more for them. Where there is an inequality in the policy derivation, how it can be. So all the places there are inequalities. Inequality for everyone, I think we must be more strongly embedded on the word gender inequality. So this is nothing related to that. Of course, there is also gender inequality. Still, there are so many inequalities at every level of AIDS management and prevention of the policies. So every level, this inequality lens has to address that and closes the gap to achieve the AIDS pandemic. So this is what again, so achieve this. So here they have mentioned they are visualizing through this inequality lens and they have set out new targets and policies. So since this global AIDS strategy is between 2021 to 2026, so our aim is like we have to reach the targets at least by 2025 so that we could finalizely underestimate around 2026 what is the status of this, so that whether we could implement further or we could proceed in the same way or we could do some alterations in between, because we have to make sure that by 2030, the AIDS is not going to be a public health threat. So what are the targets? So what are the targets we should ensure by 2025? Less than 10% of the countries have punitive, legal and policy environments. Less than 10% of the people living with HIV and key population experience the stigma and discrimination. Less than 10% of the women, girls, people living with HIV and key population experience gender inequality and violence. It actually seems to be like a little disruptive, but it is very clear. See, the major problem, as we discussed in the panel discussion, is also where the implementation is going on, where there is an inequality. So to whom it is intended, they have to be targeted. So this is the whole concept of this targets even. So what they are telling, so let us pursue that. So before going on detailedly, is there any student who is willing to give a try on what is key population? Who could be the key population we are talking about? Okay. Anyone want to give an attempt? Okay, fine. So key population was those people who are actually the high risk groups. Say, for example, high risk groups, not only for getting HIV, for all this implementation related issues. So what we are telling, even the patient living with HIV. So these are not going to be the high risk groups when we tell it in as per the term. But for this strategic plan purpose, the key population also include this patient living with HIV, and also the persons who are sex workers and homosexuals, IV drug abusers, prisoners, and those who those who were present in. So all these persons are at higher risk of transmitting the disease. And apart from that, the transgender group, more specifically, the more affected persons are transgender women. So what are all the problems they face? Is you can clearly see that there are stigma, there are discrimination, and there will be a strong violence. So these two things target making that it has to be only less than 10% of this type of people experiencing the stigma, discrimination, violence, and inequality. On the other hand, you can see that there we spoke about the criminalization law. So already these people are being neglected. So when they have been branded or they have been legalized with a lot of punishments, so it will be on the other side. These things will go like a bit unseen, but it is not going to stop. So the measures has to be taken. The target is made like that. The less than 10% of the countries can have, though it is not acceptable. Okay, it is acceptable up to 2025. Okay, less than 10% of the countries can have. Punitive is nothing but a punishable, more of punishable offense. So punishable, legal, and policy environment. So less than 10% punishable and legal policy environments for countries, less than 10% of the people having stigma, discrimination, inequality, and violence will be your targets. So what could be the priority actions to achieve these targets and results? So first, as we discussed in the panel discussion, so creating an enabling legal environment. See, I never meant that there should be no law against the things which is already existing. I just wanted to tell that there should not be a criminalization or highly punishable laws. See, only when you do that, people start doing it underreported and hiding it. And people say, for example, if the sex work is not commercialized, if IV drug abuse is highly punishable, and this is all happening. So this is all going beyond our vision. So the data reporting system will also be less. So it keeps on circulating like that. The habit will also get circulated. The persons who are transmitting the infection will also never be line listed. So all this will increase the burden of the disease. Maybe the reporting will get decreased, but the burden is never going to get decreased. So when we make the things as an enabling legal environment, we can make some laws right from, see, if everywhere still there is a high, you can see in every report there is an increasing IV drug abuse. What it means actually, the drugs are being produced, so that the various kanjas and all those are still cultivated. It is being produced, but because it is completely punishable and all, so the things is not being registered. So once we get to, people may think why we are not supporting for punishing things, but it's not like that. Once we are allowing that, this is the limit which has to be there. After that, it will be punishable. So you can always have a check at those environment. You can always have a monitoring. So you can always like implement so many laws on that. So the people will also be acceptable, and it will not be like a hidden population. So including laws that criminalize sex work, drug use, possession, personal use, and HIV exposure. So all this has to be decreased, and introduce and enforce protective and enabling legislation and policies. Okay, fine. We are, if as Sucharita ma'am said in her panel discussion, that 40% of the persons were following the sex work when they were in the transgenders. So what could be? So, okay, fine. We are criminalizing that event and we are going to stop it. So how are we going to support them for their living? That is the main thing. So here, it's not just about stopping or completing the legal environment. We have to also enforce the protective and enabling legislation. What is the other thing? What is the other occasional training you are going to give them? How are you going to support their family? If it is going to be like that, definitely you need the list of the participants, list of the high risk groups. Only then you can implement it. So you have to there has to be representation. So from that particular community, if there is a representation, that will be of more effective. So for community monitoring, in the sense whether they are getting the for HIV, the more common cause of transmission is sexual transmission. So this high risk groups are also mostly the common cause of sexual transmission, apart from the IV drug abuse. So there is also a possibility, but the transmission route may differ. So we can have a track on this when legal literacy program. So what all they were not aware whether the contraceptives are available free of cost, whether this actually there are policies which provide contraceptives, and there was permanent sterilization method for so this type of facilities are available in free of cost, but they are not aware of it. So one person from the community should be involved in getting the legal literacy program, which makes it more worth because they disseminate the information to all of their community. So for ensuring an accountability for HIV related human rights and violations, we have to make them accessible to the justice and also to involve them more towards the legal literacy program. Sorry, I don't know why this slide is not changing. Okay. So prioritize advancing the rights of people. So living with HIV population. So this is just what we spoke, ensuring that all elements of the response from provision of HIV, if we have to include them. So the rights is not just giving the medicines, it's not just giving the health education. From the provision of HIV service for involving them in research, including them in the monitoring. So including them in the monitoring, I mean like if there is a policy to be implemented for this group of people, if they are itself involved in monitoring the activity, they will be the best person to tell whether the policy is implemented in a proper way or whether there is some deviation with that. So rights affirming and that they are engaged people in living with HIV. What are they going to do for the people living with HIV? I'm so sorry. Living with HIV, whether there going to be some occasional form of training, and ensure that digital health technologies and innovations advance the right to health. There are a lot of digital technologies and innovations for everyone, for the common people, for making the accessibility. But for this people also, apart from, the transgenders are the worst affected for the rape. We know that the rape, India is exceeding more than what is needed. See, it is the highly punishable thing, but the transgenders, which we think are the most neglected, and they are the reasons for creating more number of rapes and all, but they are the worst affected. So all this digital technology and innovation should not affect them in the violations and other way. Instead, should guide them in accessing all the health facilities. So next is, so these are all the 5 critical elements of this global strategic plan, which has to be taken in account to achieve this global strategic plan to end inequalities and then to achieve the end of AIDS pandemic. So first one, community-led, this is very important. So first, initially we saw 3 targets, which is 10% each. So now we are going to see about 5 critical elements of global strategic plan. First one is community-led, community-based infrastructures, equitable access to medicines, vaccines, and health technologies, supporting workers on pandemic. I'll just come back again. Supporting workers on pandemic front lines, human rights at the center of pandemic responses, and people-centered data systems. Am I audible? Ma'am, am I audible? Is there an issue?
Yes, you're audible, but your screen has not been shared.
Okay, I'm so sorry. May I please know from which slide? Is it from this slide or from the first slide?
Yes, ma'am.
Oh my God, you must have told before, no? Okay, I'll just go very fast. So this is about the inequalities. These are the 3 targets which we have to keep in mind. Less than 10% of countries having punitive. See, the legal policy has to be unpunishable, less punishable, and it has to be enable friendly. And the key population should overcome stigma, discrimination, and inequality and violence. That has to be only less than 10%. So this is what we were discussing before. So I think we will move up. So these are the 5 critical elements of global strategic plan which is required. So the community-led, community-based infrastructures, equitable access to medicines, vaccines, and health technologies, supporting workers or pandemic frontlines, human rights at the center of pandemic responses, people-centered data systems that highlighted it. See, you can remember a basic concept. See, whenever we say that what all is needed for HIV/AIDS, so we have to think like that. We told already we have to involve the community which is needing that. So it has to be a community-led, community-based infrastructure. So next we have to think what are all will be available in the infrastructure. There has to be medicines, there has to be vaccines, there has to be health technologies. For that, there have to be equitable access. Apart from all this in the infrastructure, we need frontline workers. So we have to support work. We have to give a support system for this frontline workers. So apart from this, we know before that there is a rights and inequality related issues. So that has to be addressed. So these are the 5 strategic plans. So first is community-led infrastructures. What all this present in the infrastructures, medicine, vaccines, and technologies. You are supporting the doctors. So frontline workers supporting human rights and inequality addressment. So first, let's go to the community-led and community-based infrastructures. See, this, as per the name suggests, it has to be led by the people. See, the led by the people who are most often excluded. That means the high-risk groups, what we saw before. Apart from the routine system, see, if there are systems which is supplying this, you know that there is an STI clinic, Suraksha clinic and all, let it go by the side, but there has to be a system for themselves. So let there be a system, let there be a clinic for the transgenders, let there be a clinic for the sex workers, let there be a place for IV drug abusers. So when it is like that, the people themselves will be easily going to those places compared to the common places which is known for that HIV. So known for that HIV common general population. So these people will also get in to know who are all in the community, and they will the purpose can be filled properly. So failure to reach critical parts of the population is the main reason for making the small outbreaks to become an epidemic, and this epidemics to turn into a pandemic. So what are the 3 key roles we have to think about is that where we have to think is that providing services, yes, they have to get it involved, bringing community insights to planning and decisions. They should be in a position of being a part of policy making and supporting accountability. This accountability is not that during the procedure or the implementation time, even during the monitoring activity, what all or should be the indicators. Say, for example, like if I'm service providing is going to be the supply of contraceptives, for accountability, for monitoring purpose, I could check incidence of STI among the persons who have been supplied with contraceptives. That will tell me whether the service is properly utilized. So for that planning purpose itself, the community has to be involved. In both AIDS and COVID-19 pandemics, national programs have struggled to, this is the most important thing. See, even in the COVID-19 pandemic, initially the major reason for the extreme worst situation is because of this rumors, misinformation, mistrusts, and the stigma. The person who are COVID positive, they stop telling that they are COVID positive because they will be treated like an aliens. And then there were a lot of rumors. People said that there is no such COVID. People are creating about that until they get the disease by themselves. And there were a lot of mistrust, misinformation regarding the vaccination, which all have piled n number of deaths in almost every family. Almost if most of the family members have lost, family has lost at least one family member due to a COVID-19, which is all because of all these things, apart from the COVID-19 strain itself. In many of the most effective AIDS responses, see, this is based on the previous experiences. We have got this idea in this, we are including the idea for this particular national global strategic plan, that the community-led organization have been engaged to convey. So to overcome this, see, if I am going to tell, no, there is no such disease called COVID, no one is going to believe. Sorry, if I'm going to tell you there is a disease called COVID, no one is going to believe. So if the person affected in the family member, one is getting affected with COVID, and he says that, yes, it is true that there is a COVID disease. So it has to be some evidence-based prevention and treatment information. This has to be given by the community which is getting affected. So it will be more relevant than the government officials telling, no. So this affected community, when they say that there is a treatment for this, they believe that. So all the misconception and rumors can be overcome if it is most effectively communicated through the affected community. And this, as we spoke before, the HIV services for the key population which is experiencing discrimination can be provided by the key population itself to be more effective. To get the AIDS response on track, full engagement of this community-led infrastructure must be universal. Again, there should not be any deviation towards whether it is going to be urban-oriented, rural-oriented. Everywhere it has to be an universal. Wherever this community, affected community is going to be there, or high-risk group is going to be there, there has to be such an community-led infrastructure. So our main aim is that they have to be included. They have to be strengthen the community health workforce, the support the collection of community generated data to protect rights and meet the needs of people living with AIDS. The most successful AIDS pandemic responses from various other countries understood that people place greater trust in their own communities than the government authorities. This is what we have discussed before. So see, instead of just involving them for 1-2 meetings, we have to make an organization for this community, like an NGO, no? For each of the diseases or each of the procedures, we have a lot of NGOs. For example, for palliative care, we do have an NGO. For leprosy rehabilitation, we have an NGO. For everything, we do have an NGO. I'm not telling such a non-governmental organization. The government should take an initiative to create an organization with the affected communities. That is the patient living with HIV. For them, they have to create an organization. If the person who are doing a sex working, they have to create an organization, and those organizations should be considered as a full partners, as they have to be involved in governing, designing, planning, and budgeting the pandemic response. And for that, we can just train them for all this, and it is the responsible of the government and the organization to provide the technical and financial support to do so effectively. So first, we saw about the community-led infrastructure. Now we are going to talk about what is available regarding what is available in the infrastructure and how is about the accessibility. So equitable access to medicines, vaccines, and health technologies. So I'm just quoting regarding the COVID-19 pandemic situation for the equitable access, which is same for either it is going to be HIV, either it is going to be for malaria, either it is going to be tuberculosis, any issues. Okay, and detailed description of this will be taken by the other presenter. So intellectual property rights selective waiving. See, at the start of COVID pandemic, so you could relate it better. COVID pandemic, there were so many, everyone were trying very badly to find out, to search for that where I will get tested. Testing centers were less. So we were all in line to get tested whether we had COVID positive or not. Then we were all fighting, and we were all waiting for the remdesivir. Whether that worked or not is the second thing. We were all waiting, and so many pharma company has come across for providing the remdesivir. And there were a lot of malpractices which was formulated in the pharma companies even. And there were a lot of difficulties in getting the vaccines. So what was they told us, please give us a temporary waiver. So a temporary waiver and the cost was extremely high for remdesivir or for any diagnostic purposes and all. So they were expecting a temporary waiver, at least during the pandemic period. We need some temporary waiver. Likewise, HIV is going to be a routine pandemic. We need a temporary waiver. So there's not going to be a temporary waiver until the pandemic ends. We need a waiver for all those things. But though it is expected by 100 countries, more than 100 countries, still there are many countries which withheld their support because of the financial benefit they are getting. And the broader use of technology has to be there, and facilitate voluntary licensing, and every licensing has to be in a transparent way. But most often it is not accepted because of the monetary benefits they are giving. Next, supporting workers on the pandemic front lines. So this is very important because we already know that doctor population ratio is very less. Health workforce has to be utilized very carefully because the manpower during the time of pandemic is very, very, very efficient. It has to be tackled very efficiently because the health work focus can also be organized more effectively. It has been estimated that more than 3/4 of the nurses and doctors perform tasks which they are overqualified. See, for certain jobs, we know that of course, the doctors has to treat the patients. For all this invasives and all is fine. For attending the patients, for going there and checking, for this and all, no, for giving medicines, for this and all, every time during the pandemic situation when the beds are flooded with patients and there are a lot of patients waiting for that. So it's not like if the doctors and nurses are getting involved in this type of work, automatically in return, the patient's benefit is only going to get affected apart from the mental health of the doctors and his own health benefits. So what we have to do is we have to redistribute the tasks to health workers with shorter training and fewer qualification. Okay, so we have to train them with fewer qualification, including the community health workers, task sharing. So this will be the important source for major breakthrough HIV. So this adaptation also reduce the workloads of doctors and nurses and allow their services and procedures to be decentralized. So everywhere they can, it's not, so once the work is shared, they could be in a larger places and even in the peripheries to support their communities. And similarly, since HIV medicine, we think that HIV medicine prescription was previously in certain countries where the HIV AIDS response has been successful. What they did was they even allowed the nurses to prescribe the HIV medicine and the lay workers to assist in dispensing the medicine. Nurses were prescribing and the lay workers were dispensing. You may think that it is going to be hardcore. No. Actually, when there is a proper protocol for any treatment and it has been trained adequately and it has been evaluated adequately, it is acceptable fact that nurses could be a person to prescribe the HIV medicine. And when it is told and trained, and when they should be given a proper training to overcome this manpower deficit. So next is human rights at the center of pandemic response. So this is where we are missing most of the thing. So human rights are the central. So decades of research have demonstrated that human rights-based approaches was overcoming the power imbalance during the crisis of pandemic. And it is also seen that increasing their risk of acquiring HIV and that make it difficult for them to access the treatment and remain in care. So it is about the people. So you can be very clear who are all at the greater risk. Depending upon the place and context, these populations include women, girls, gay men, and other men who have sex with men, and transgender people and sex workers. These are all the population who are at higher risk of getting the disease. And these are all the major chunk of population who are also transmitting the disease. But the poor situation is that the accessibility and the acceptability of this group of population, both for inclusion and the treatment, is very, very less. And it is against the human rights. So it is our responsibility, or it is under the National Global Strategic Plan, that we have to concentrate on improving the human rights for this particular group of community so that they get the access and also the inclusion. So again, we have just told about the criminalized law policies and all regarding the discrimination in this para. Criminalization and punitive laws and policies based on sexual activity, sexual orientation, and gender identity, drug use, HIV status, and further expose adolescent girls from the populations to extreme levels of violence, stigma, and discrimination. So, see, whenever we post some criminalized law, so what is it going to do is that it is going to drive them further from accessing the HIV prevention. Okay, fine. If I'm going to be HIV positive, if I'm going to tell that, then I'm not going to be like included in the society. So automatically the person will stop disclosing that he or she is going to be HIV positive. The result is that he's not going to get tested. He's not going to be taking medicines. So automatically he will be a source of infection until he is going to get cured. So there has to be a law which is enabling. That is what we spoke before. So this is only for that. So people, this is the last part of the element. So people-centered data systems that highlight inequalities. So everyone are aware that the speed of data collection in COVID-19 itself is a remarkable achievement, and it is a really appreciable thing also. So like how many cases have been reported, how many aggregation, and everyone of us is also aware, even the system is very strong to collect the data. We are also aware that how many cases are left out. So that is the different part. But what is often missing from this data is that who is most vulnerable to the impacts. If I'm going to be a COVID positive patient, my data will be given. And if my family, there is a kid, there is a elderly parents, so data regarding that will not be there. So this has to be identified. Okay, so only then I can control the pandemic. So they have to be, so only the data of count what is going to, who is going to be positive is not going to control the pandemic, is what is meaning here. Whether it is going to be COVID-19 or it is going to be HIV pandemic. If someone is HIV positive, collecting a data regarding the prevalence or incidence of HIV, so if I say one per 1,000, that will not be suffice to control the pandemic, because that one person is in contact with how many. You must have come across a snowball sampling for your research data. But that type of measures should also be taken for the survey. So we have also test all those people. So that is the most important thing. So community-led monitoring. So for such a test, instead of the general population getting involved themselves to identify whether you were positive or you were positive, so community-led, that particular group of community-led monitoring is increasingly being used as an accountability mechanism to empower the key population and the other groups. It reports to HIV program. So what it does is that, see, you can see that it will contact all the communities which is related to that, related to HIV, and it systematically and routinely collect, analyze the quantitative and qualitative data on the HIV service delivery. Then based on this will report to, this was a famous successful project in Nigeria, which was involving the community-led monitoring program. So they will be reporting regarding the program managers and the decision makers, and what was working well and what was not working well, and what needs to be improved, and what are the suggestions for this targeted action. So if it is followed in our country also, this could be serving as a best tool to end the AIDS epidemic. So many do not collect sufficient data on priority population, which can leave most of them. So this has to be, community-led monitoring has to be a definite source for transforming the HIV treatment programs. So you could see that this model is involving community members and involving them in quantitative and qualitative data. And you can see, again, I just mentioned the same thing. The supervisors will verify whether the data collected is correct. And based on that, the advocacy program is followed and improvements. And when there is a proper monitoring system at every level, there will not be a time when there is drug stockouts, and there will not be a time when there is poor service quality. And don't think whenever I say there is a community-led monitoring, it is only at the end of the program. Everywhere simultaneously at each stages of the program, only when the program is evaluated, that is going to be effective, because only then we could put our inputs, and only then we could also identify the gaps and overcome that. The community scorecards were also, this is the other successful model. In Vietnam, they will be using community scorecards. Based on that, the satisfaction and the services provided, and what is the drugs they were getting, what is the difficulty in accessibility. So everything will be in the community scorecards. And community members and the health staff, they have to jointly develop a set of indicators for the rating of the services. So these were all the examples of how it has to be. So I think we could stop. If there are any participants who are willing to tell that what could be the targets of this global AIDS strategic plan, anything if you remember, we could just go with that. And if you have any questions to ask regarding that, you can kindly ask. I'm ready to answer.
Yeah, Thank you, Dr. Suganya. Can you stop sharing the screen? We can have the question and answer interactions.
Sure, ma'am.
Yeah, that was a wonderful deep dive into the strategy for the next 5 years. Am I audible?
Yes, ma'am, you are audible. Thank you.
Thank you, because your video transmission seems to be frozen at some times. Yeah. It was really a complete deep dive, as I said, like we are able to understand what is the strategy for the next 5 years. You have taken us in depth into how we are going to address this in the next 5 years, because having short-term goals for the next decade is extremely important, as Madam Tenmoni Valima also highlighted. As policymakers and leaders, we need to have mid-course correction in mind. We cannot approach to tackle this problem with a decade approach and think like at the end of the decade we are going to achieve it, because pandemics are emerging, a lot of variants are emerging, and we are facing daily challenges. And with multiple infectious diseases assaulting us from all sides, and in countries with low income resources, we need to address this. Now, leading the discussion, we have received some questions. Personally, also, we are having parallel discussions when you are talking the session. The WHO has identified that the division, disparity, and disregard for human rights are among the failures that allowed HIV to become and remain a global health crisis. And
Yes.
the session has highlighted that people-centered approaches has to be the focus for the next years. And during our panel discussion also, we highlighted the high-risk group populations, vulnerable population. These are the terms we picked on repeatedly. So when it comes to human rights approach, because these are the population you also highlighted, it's not just about providing accessibility and utility of those services. These vulnerable population by default are not having access to basic information. So could you also throw some light about how these vulnerable populations can be empowered about the human rights concept, such that health is a human right, and accessing that healthcare and receiving that healthcare to remain healthy is a basic human right for this vulnerable population in the context of HIV?
Okay. Ma'am, as you clearly said that the basic needs are also, there is a difficulty in assessing by this group of population. For related to HIV, ma'am, like this marginalized group, though there are very less in number, they often tend to remain in group among their community. So if we give a try to track them, first we have to map those people where the locality, maybe we could get some data, but still we need to go and we could to tell practically, even our college, Tagore, there, that is also our college. So there were all the students were getting involved themselves in a lot of, I remember they were organizing so many camps. Apart from that, in the college, they were also like providing NGOs separately, they were tackling NGOs. So maybe I feel that students community itself is the best community to tackle this, because they have to include, because they are also in this phase, they will be more enthusiastic in helping out them. So they can identify certain groups and they can address first what is the need, community need assessment. So each community need assessment has to be made. So for this particular HIV, what is their difficulty, whether they were difficulty in, what is their difficulty in accessing? There are hospitals, but there is no separate clinic for them. Whether see the doctors itself, even in our syllabus, ma'am, right now, the medical curriculum is imparting lot of knowledges diversely about treating patients, but it is not more specific towards transgender treatment. So we are not aware what is the problems they face on hormonal therapy and what are all the issues. So everything has to be addressed. So like likewise, if we themselves create, we ourselves create an organization and help them to create an organization and educate them what are all the policies available, I think this could have been overcome.
Yeah, that's wonderful. And I would like to remind, yes, Tagore is still our college. You belong to our Tagore family. You may be anywhere, but you still belong to our family only. Don't worry about that. And coming back to one more question, it is predicted that 7.7 million more AIDS-related deaths could occur over next 10 years unless world leaders start tackling stark inequalities. And you just now highlighted how community participation led efforts jointly by all parties, including medical colleges, our student communities, our joint efforts through outreach camps involving the NGOs is extremely important to address this. And as you correctly said, right now we are doing the same approach. And this year, maybe you missed it, but on March 8th, the Tagore Women of the Year Award for International Women's Day is conferred upon Born to Win, a community-based organization which is taking care of trans community needs, Shweta C. Sundar. She was the Tagore Women of the Year Award. So our institution, led by Professor Dr. Mala Madam, she's always oriented towards identifying this kind of leaders, championing the cause of vulnerable population. And you can visit the website. That Women's Day picture is there, where we are conferring the Tagore Women of the Year Award. And today, unfortunately, we had her session where she was about to talk about populations left behind and closing the gap, community leaders' perspective. I just spoke to her because of the latest floods. Their organization, Born to Win, is delivering so much of services, flood relief campaigns, flood relief camps, and relief materials to their affected population. Unfortunately, she was down now. She was sick now, and she could not be part of our webinar, but she's a great leader. She represented her community and their needs at UN level. You could go and check her profile too.
Sure, sure.
So, through this webinar, again, I would like to draw attention that unless we all put our efforts together, your son is behind you.
Yeah.
Extremely curious why my mother is talking so much.
He's just got up. He's
budding champion. He will also contribute.
He got up. I'm so sorry for all the interruption. I'm just.
He is part of our live AIDS webinar.
Yeah.
Champion is in making.
Yeah, thank you.
Thank you so much for bringing him to our attention. So the concluding point is, I just want to draw one point here. There is this interesting thing. HIV prevention services have been impacted in 2020 because of COVID-19, and harm reduction services for people who use drugs are disrupted in 65% of 130 countries. So this is one more concept. You may be aware, Dr. Suvanya, when you are here, we were doing a lot of tobacco harm reduction research and all that. We are continuing with that. And because of the pandemic, these services are constantly impacted and affected. And if your time permits, after the lunch session, we are showcasing the posters presented by undergraduates, interns, and postgraduates. So we are going to showcase all the posters presented by them. But otherwise, we would like to thank you for your valuable session today. And you have highlighted all the points, especially the strategy for 2021-2026, the global strategy. And I think the national policymakers sitting at National AIDS Control Organization and state AIDS control societies today are commemorating World AIDS Day. And they are going to take note of your presentation in the global strategy, and they are going to draft our national policies, and they will be reflecting our needs and gaps because of COVID-19. I definitely believe that your points will definitely be reflected in the policies, and hopefully we will be able to interact with you again in the next year. And I request, because of your expertise,
there is an audio disturbance.
Yes. Kannan sir, can you mute other participants? Yeah. I would like to repeat that in 2022, I will be approaching you again and requesting, given your expertise, to take some classes for our postgraduates also.
Sure, ma'am, definitely.
Yeah.
Thank you.
Now I would like to formally present you with the certificate for your valuable participation in our webinar. And Kannan sir, can you present our expert?
Excuse me.
Yeah. This is a certificate of appreciation presented on behalf of our Tagore Medical College to Dr. Suvanya, the Assistant Professor of Venkateshwara Medical College, for being part of our webinar. Thank you so much.
Thank you so much, ma'am. Thank you so much for this.
Excuse me, ma'am.
Yes, I know.
Ma'am, Dr. Keerthana, postgraduate community medicine.
How are you?
Yeah, ma'am, fine, ma'am. How are you, ma'am?
Okay. Yes, ma'am, fine. Yes.
Can I have one question, ma'am?
Yes, please.
Sure.
Yes. Ma'am, you have said we can have organizations for this, for people living with HIV, like NGOs.
Yes.
Can it be more stigmatized, ma'am? How useful it will be, or can it become more stigmatized for the people?
No, ma. Actually, see, whenever what I mean, see, on the practical line, everyone are clear. Is it audible?
Yes, ma'am.
Is it audible? Okay. See, everyone are very clear. There is a stigma. We have to accept. Let us not boast that there is no stigma and all. We need to accept there is already a stigma. So people
Yes,
are not coming if they have to meet a group of people who are the persons who are stigmatizing and discriminating them. Say, for
yes.
example, if there is a representative of the transgender group, there is an organization for the transgender group particularly, so they will all be happily joining in that organization, and they will be telling their issues related to the HIV service delivery or the benefits or the issues, whatever, in a better and a proper way compared to the normal organization that is not their community. So that is what I want to mean. And for that, from your side, being a public health expert, from what I was telling about the student panel, so you can identify what is the need they expect from you people. Apart from the monetary benefits, what they need some knowledge, like there are so many schemes of providing the contraceptives, and you are more aware of that. I think you have worked in government also. So
Yes.
there are also for providing the contraceptives. Maybe you can divert them and for benefits of these people, because they are the persons, or they are the key population who are going to spread the disease. I meant the organ, so that is not going to be stigmatized. Even that is
Okay.
going to be more powerful. So once
Okay.
this organization get utilized, and when it proves to be successful, then the representative of each organization could mingle in the policy making, so that whatever policy you make, no, so it will directly identify the lacuna what is experienced by the group. So I feel that organization should be there.
Okay, ma'am. Thank you, ma'am.
Thank you, ma'am.
I'm Dr. Umat, ma'am. It's already in ART and ART link centers, ma'am, which is available in our state, which is
Okay.
providing this kind of specific group, target group services for these patients living with HIV only, ma'am.
Yes, sir. Yes, sir. It is already existing. But what I'm telling is, as you know, that though there is always the problem of existing is there, but how far it is working is what is the major problem. Where it is existing. See, if I don't want to ask, but the fact is that we will not be able to list which are the places which is existing even in Chennai. So that has to be, so when we are not able to list out, how will those people who are completely unaware of there is a system which is existing will be aware of that? So that is what I'm coming to make. So first, identification by social mapping or any such mapping methods, the key population has to be identified. It is not just about the transgender population. That you, as you said, there is a sex workers, there is a separate organization. I do agree, there is for transgenders, it is a separate organization, but only the organization is more concentrating on places where there are more number of sex workers. It's not for the places where such community is dispersed widely. They are not getting the benefits. Unluckily, those who are dispersed widely will be the source of spreading the disease also widely. So that has to be an organization that everyone has to get. For doctors, if there is an IMA, for likewise, I'm telling, for every group, there has to be a representative organization for making it more feasible.
That is a wonderful interaction from my PGs. And a point. Kanan sir, please mute the other participants. Naga Prashanti, can you please mute yourself, Dr. Naga Prashanti? Thank you. And that's a well highlighted point from Dr. Vinod Raja, the senior PG in the department, sir, comes from health administration. As highlighted by the speaker, in spite of existing systems capturing those things, sir, the current World AIDS Day theme is end inequalities. So they are acknowledging, in spite of the existing systems and methods to capture those data, inequalities are persisting. So we have to think out of the box, existing systems, and go beyond them. That is the point, again, highlighted by the speaker. We have to go beyond them. Yes, systems are in place, but they are not yielding the best of the results to put an end to the epidemic And her point is we need to put those extra efforts to go the extra mile. Thank you so much. And we would like to say thanks once again to our speaker, Dr. Suganya. Thank you so much. It's been a pleasure to have you from the morning. I think your son is missing you. Thank you so much. We look forward to interact with you again. Stay safe, and we will contact you for our PG's classes. They are extremely inspired by your talk, and they will interact you with a formal invitation for their classes. Please open for their request. Thank you.
Thank you, ma'am. Thank you so much. Thank you, ma'am. And all the best for all the students who are here. Actually, still many are in contact with me. They were telling that they got their results. And I'm very glad that I'm taking a session. It's almost like a class for me to take up. Thank you, ma'am. Thank you so much.
Thank you all. Now we'll take a short break and reconvene at 12 o'clock for Dr. Arvind's session. Thank you so much. Series for World AIDS Day 2021. It's jointly organized and conducted by Departments of Community Medicine and Microbiology. Moving on to our next session, we are happy we are joined by Dr. Arvind M., the Associate Professor of Department of Community Medicine, Chettinad Hospital and Research Institute. Dr. Arvind, we welcome you once again. Are you online, sir?
Yeah, thank you, Doctor.
Yeah. So before asking Dr. Arvind to start his session, I'll give a brief introduction about his career. His experience is over 9 years in the field of public health and community medicine, and he has published 12 articles on national and international peer-reviewed journals, and which has been cited by greater than 60 authors. And his H index has been around 4 and I-10 index is greater than 3. And as I mentioned earlier, one of his publications has been quoted by WHO. And he's been part of clinical trials on rabies vaccine and rabies immunoglobulin studies. And he's member of organizing committee in various conferences and workshops. It's been our honor to be associated with Dr. Arvind, and thank you so much for accepting our invitation to be part of this webinar. And today, Dr. Arvind is going to be, all of you have been part of our webinar, and he's one of the panelists. Along with that, today he also accepted our request to be a speaker for this session titled Tackle HIV and COVID-19 Together. All of you and us have been discussing since morning how this COVID-19 pandemic has impacted HIV and AIDS scenario globally. And in this session today, Dr. Arvind is going to share insights how to tackle HIV and COVID-19 together going forward. Dr. Arvind, we welcome you.
Thanks for the opportunity, Dr. Sri. And shall I share my screen?
Please.
I'll keep my video off so that to work on the network problem.
Yes, please. Your screen is visible, doctor.
Yeah. I'm just smiling. Is it full screen now?
Not yet.
I made it already. Should I refresh again?
Yeah, please refresh because it's not yet full screen.
Just a moment. I'll stop sharing and I'll do it again. Is it fine now?
Yes.
Yeah.
Good afternoon, everyone. As Dr. Shri has told, the topic for my session is tackling HIV and COVID together. So, COVID is a pandemic, HIV is also a pandemic, and we are trying to overcome a syndemic now because the COVID has impacted the health infrastructure and health delivery, and one of the major impact has been observed in HIV. Okay, so in this background, I will be seeing this presentation. So the problem statement, the coronavirus disease is an infectious disease caused by SARS-CoV-2 virus. Most people infected with the virus will experience mild to moderate respiratory illness and recover without requiring special treatment. However, some will become seriously ill and require medical attention. Older people and those with underlying medical conditions like cardiovascular disease, diabetes, chronic respiratory disease, or cancer are more likely to develop serious illness. As everyone knows, the first case of COVID-19 was reported exactly 2 years back. And according to current data, throughout the world, 26 crore people have been diagnosed with COVID-19 as of November 30th, and 52 lakh deaths has been reported worldwide. In India, 3.4 crores cases and 4.69 lakhs deaths has been recorded till November 30, 2020. HIV, coming to HIV targets the immune system and weakens the people's defense system against many infectious and other type of cancers, for which normally the healthy people will be able to overcome. As the virus destroys and impairs the functions of immune cells, infected individuals gradually become immunodeficient. The most advanced stage of HIV infection is acquired immunodeficiency syndrome, which can take many years to develop if not treated, depending on the individual. Of the nearly 40 million people living with HIV worldwide, most live in countries with poor healthcare infrastructure, and majority are over 50 years in several countries. India is the second most populous nation and is home for 23.49 lakh people living with HIV/AIDS. So India is the third most affected nation with HIV. As told, this is pertaining to 2019 data. Adults accounts for 0.22%, whereas children comprise of 3.4%. Maharashtra is a leading state with 3.96 lakh infections. Till July 2020, there are around 570 ART centers and 1,264 linked ART centers running under the National AIDS Control Program. So, how this syndemic is affecting the social determinants? Syndemic means two pandemics going together. Here we are dealing with HIV and COVID-19. So, in these challenging times of COVID-19, the pandemic has severely affected the lives of these HIV-infected immunocompromised patients. AIDS patients are fighting against several pandemics of the virus, including COVID-19 infection, access to food, nutrition, treatment, and their social life. So these determinants has been affected. All the resources and infrastructure made towards managing HIV/AIDS has been shifted towards COVID-19. So as I pointed out in the morning, the governments were clueless and the policymakers were clueless, and we wanted to concentrate mainly on COVID-19, leaving the other. The planning was not in a phased manner, so everything has been concentrated towards COVID-19. This has completely disrupted the services implemented for the management and prevention of HIV infection. So many countries imposed complete lockdown, even India, to combat COVID-19. But the situation worsened the HIV/AIDS patients who needed continuous monitoring and regular follow-up checkups. The HIV patients find it difficult to get antiviral therapies, increased stressor. This leads to increased stressor if they fail to visit the doctors. So the mental health component has also been affected. Negative consequences of COVID-19 for some population are more severe than others. So among the many disadvantaged carers, COVID-19 era, in COVID-19 era, people living with HIV/AIDS and people at risk of contracting HIV, such as sex workers, people who inject drugs, and men who have sex with men, and people with other autoimmune disease, are considered to be most disadvantaged because they need, as I've already pointed out, they need a continuous follow-up treatment. Okay. So the pandemic has led to significant changes in health service delivery and amplified fear of increased death and illness. The health inequalities, and the consequences of these changes among various subgroups of those living with HIV or at risk of contracting HIV must be reviewed through a lens of social determinants of health. So coming to the determinants on which we are going to see, the coexistence of AIDS and COVID-19 infection is poorly understood. So all the below mentioned determinants, there will be two school of thoughts. There may be contradicting statements from different parts of the world, and we have to review everything. So when I try to review all these things, I didn't get a solid paper because most of the papers are in development at on the stage of manuscript writing and all. So I found a good review article which helped me to find these particular determinants and how different people from different part of the world are perceiving these determinants. So we'll be seeing about prevalence estimates, mortality estimates, comorbidities, pathogenesis, opportunistic infection, development of antibody towards COVID, pharmacology, and vaccines. So regarding prevalence, no evidence that COVID-19 prevalence among the people living with HIV is significantly different from that in general population. So as I've already pointed out, there are few small studies where they have done a case series and they have told that prevalence is more among COVID-19, prevalence of HIV is more among COVID-19 individuals. The vice versa. The HIV individuals will be more prevalent for this COVID-19 disease. But that was not case in other the bigger studies where the cohort has been used, and it was found it was almost similar to the normal population, such as those who are in elderly age group might be having more prevalence. The same way, HIV, those who are elderly might get a similar amount of prevalence. Mortality, several studies have noted that COVID-19 mortality among the people living with HIV does not differ from the general population. There were no difference in hospitalization or ICU admission, intubation, or death by HIV status. And evidence of significantly increased COVID-19 mortality rates among people living with HIV comes from a cohort of individuals accessing public health care in South Africa. So this was one of the contradictory evidence. HIV positive individuals have a significantly higher hazard ratio of mortality than individuals without HIV for control of age, diabetes, hypertension, chronic kidney disease. Next, coming to the comorbidities. Question about whether comorbidities are confounders or effect modifiers are important and still unclear. So this was mainly untouched in many of the studies. Regarding pathogenesis, two contrasting hypotheses have been reported. The first one is the relative immune suppression from HIV may make people living with HIV more susceptible to contracting COVID-19. But the lymphopenia that may protect against severe manifestation of COVID-19 due to an immunity demand and overactive T-cell response. And the second school of thought is that prior studies have shown that HIV-1 infection is characterized by chronically elevated inflammatory state, which when combined with the cytokine storm seen in severe COVID-19 would theoretically worsen outcome. So it is also yet to be proved. Regarding opportunistic infection, COVID-19 is not an opportunistic infection. Other opportunistic infection may worsen COVID-19. It may be pneumocystic pneumonia or tuberculosis. Next is development of antibody towards COVID-19. It has been observed that slower response from limited studies. Okay, but yet to know if the varying antibodies will still prevent COVID-19 reinfection due to an amnestic response. So the memory cells, will it prime it? Everything is still unclear. But still, person who is living with HIV are recommended to take vaccine, and even CDC has recommended. The last point you can see, the CDC states that people who can have advanced or untreated HIV benefit from an additional dose. So additional dose, booster dose has been recommended by the CDC. Regarding pharmacology, initially there were theories that antiretroviral regimen can be used for COVID-19, but later it has been denied. And what the people who are taking ART should do? There is currently no indication to change ART regimen from a virologically suppressed or people living with HIV to prevent COVID-19. So they need not change the regimen. They can continue whatever they are. So coming to the challenges which we face because of COVID and HIV together the pandemic. We'll classify it into individual level challenges and national or country level challenges. So regarding individual level challenges, the fear of contracting COVID-19 has led to decreased engagement with care among people living with HIV in several countries. So already they have been affected with HIV, and what if they get COVID-19? So the worries will be there always. Okay. So because of this, there were decreased engagement with the healthcare. People who have faced stigma for decades due to their HIV status and live under the burden of chronic virus are hesitant to engage in care in the prospect of being infected with another more deadly virus is real. So this is the point. So everywhere there is a scare of COVID-19, deaths, hospitalization, everything. And these people are already suffering from a deadly virus. And still, if they want to go to healthcare, and what if they get contacted to the new virus, which is considered to be deadly again. Okay. So this fear has led some to question the safety of going to ART centers. So the lockdown has already reduced the accessibility to the centers, and many have stopped the treatment because they would not get the ART on time. And the national lockdowns have also significantly hindered the access. I've already pointed out the access has been hindered. They are fear, and all these put together, what happened? They were not able to get the ART at the right time. That too during the initial lockdowns. So later, the people have figured out how to give, like delivering the ART medications to the individuals. But initially, there were hiccups in every different corner of the world, and because of which there has been decreased in access, and they were not able to get the ARTs. Finally, physical distancing guidelines can exacerbate the high level of isolation that older individuals with HIV already face. So the physical distancing, so the people living with HIV or at higher risk of contracting COVID-19, individuals may fear that they are and result in them presenting to late to care. Okay, so still we don't have evidence, but they will be presenting very late to care. Depression is the second most common mental health disorder after substance use among people living with HIV, and constitutes an additional barrier to care. The ongoing pandemic is a significant stressor and likely to worsen the already high prevalence of mental health concerns among people living with HIV/AIDS. So coming to the country level challenges, the rapidly growing pandemic has strained national healthcare systems worldwide. Physicians have been called to care for patients with COVID-19, creating staffing shortages. Okay. So the staffs has been pulled to manage COVID-19. In government colleges, most of the PM paraclinical faculties has also been called to take care of COVID-19 patients. The same way, those who are exclusively dedicated for carrying HIV patients were also been called. This has forced some clinics to suspend in-person visits, others to postpone blood tests, and some to solely focus on ART distribution. Simultaneously, these already overwhelmed clinics are approached by people living with HIV who previously received their healthcare elsewhere, but were unable to return to home during travel restrictions. So what will happen? There was travel restriction, and they used to get medications from a particular center. Since they have shifted to some other place, they are not able to approach the nearby health centers, or they what will they do? They will come and approach, and they won't be having supplies, and they can't give treatment to each and everyone. So that was one of the challenges faced. So these challenges limit the ability of the clinics to identify individuals with drug resistance, rapidly diagnose opportunistic infection, and carry out routine blood tests. So apart from giving ART, medications, there were difficulty in finding the drug resistance rapidly, to diagnose opportunistic infections, and even to carry out routine blood tests. For high-risk individuals who wish to be tested for HIV, this delays linkage to care, making it impossible to test and treat in timely manner. So the modeling studies show that even a 3 months disruption of ART supply can lead to 500,000 excessive HIV/AIDS related deaths in Africa alone. So there has been ever since AIDS emerged and the treatment has been sorted, testing and treatment has been sorted, we have shown so much progress, but the years of work has been deteriorated because of this pandemic. The challenges to HIV care mentioned above are simultaneously impacting the TB care. So we have to bring in TB also here because it is also closely associated with HIV. So TB is the leading care of mortality among the people living with HIV, and modeling studies shows that even short-term disruption in TB diagnosis and treatment can lead to increased incidence and mortality for many years to come. So one of the major strategies to tackle the spread of COVID-19 has been encouraging shelter in place, that is home quarantine. Prolonged contact to household at the household level can lead to household transmission. So again, this will affect the years of work put to reduce the incidence. So what are the ways to tackle the challenges? So despite such monumental challenges, this pandemic creates the opportunity to accelerate much needed changes in care delivery. So the multi-month prescribing has now been taken off in several African and Eastern European countries. While this has the obvious drawbacks of limited viral load and CD4 monitoring. So we can't, we are giving the multi-month prescribing, we can't monitor the viral load of that is CD4 monitoring. It provides an opportunity for innovation in point of care testing solutions. So we have to evolve over a period of time, and this pandemic has taught the lesson to us. Moving forward, countries should work towards maintaining a steady supply of ARVs and anti-TB drugs, especially when exclusively imported. Notably, South Africa did not expand multi-month prescribing due to fears of ART shortages. So we have to keep in supply. The stocks should be kept so that we are not in a position where we are out of stocks. This is necessary to buffer health system against external shocks, especially in high HIV/TB prevalence settings. Finally, solutions must be tailored in a location-specific manner. Telemedicine visits. Okay, so telemedicine visits and how to deliver remotely ART treatment, and also decentralization. In low resource setting, we should promote decentralizing HIV testing with the help of both increased access to care and offer larger hospitals. So this can also be tried. In Spain, some non-governmental organizations are involved in collecting medications for individuals and delivering to their homes, particularly to the elderly individuals. Okay, so they are already at a high risk of contracting COVID-19. We can deliver these medicines to non-governmental organizations. But these things have been done in other countries, so we should check the feasibility in our country if we are trying to do it. The rapid spread of COVID-19 globally has created unprecedented challenge to health systems worldwide. As we have already missed the target, 2020 target, that is 5 lakh annual HIV/AIDS deaths. Fewer than 5 lakh annual HIV/AIDS deaths. We have already missed it, and we have a way forward to put things together and march towards the progress. So, Dr. Sri, if time permits, I will just brush up the frequently asked questions which has been given by CDCs.
You do have time because it's your session is slotted up to 12:30. Please brush up because students are there, interns are there.
Yeah, sure. So this has been taken from the CDC website, and which part of it which we have already covered, but anyway, I will brush it up. Just 3 more slides. Are people with HIV at higher risk of COVID-19 than other people? We are still learning about COVID-19 and how it affects people with HIV. Based on what we know at this time, people with HIV may be more likely to become severely ill from COVID-19, but still it has not been proved. Other factors can also make you more likely to become severely ill, such as age and certain underlying medical conditions. Older adults, people with certain medical conditions, and pregnant and recently pregnant people should take preventive action, including getting vaccinated, wearing masks, and practicing physical distancing. Are COVID-19 vaccines safe for people with HIV? Yes, these vaccines are safe for them as well. Do I need any additional dose of COVID-19 vaccine if I'm affected with HIV? People who have advanced or untreated HIV may benefit from additional dose of COVID-19 vaccine to make sure they have enough protection against COVID-19. Will COVID-19 vaccine interfere with HIV medicine, that is antiretroviral therapy or pre-exposure prophylaxis? Based on what we currently know about COVID-19 vaccine, no evidence to suggest potential interaction with ART or TRE. What can people with HIV do to protect themselves from COVID-19? You should follow the general guidelines. That's it. Okay. So, if you have HIV and are taking your HIV medicine, it is important to continue your treatment and follow your health care provider's advice. This is the best way to keep your immune system healthy. People with HIV can protect themselves from COVID-19 by taking these general steps, like get COVID-19 vaccine as soon as possible, wear a mask that covers your nose and mouth, stay 6 feet apart from others who don't live with you, avoid crowds and poorly ventilated indoor spaces, wash your hands often with soap and water. Can HIV medicine be used to treat COVID-19? Currently, treatment of COVID-19 is limited. Evidence does not show that any medicine used to treat HIV are effective against COVID-19. People with HIV should not switch their HIV medicine in an attempt to prevent or treat COVID-19. What can everyone do to minimize stigma about COVID-19? Minimizing stigma and misinformation about COVID-19 is very important. People with HIV have experience in dealing with stigma and can be allies in preventing COVID-19 stigma. And thanks for the opportunity.
Thank you, Dr. Arvind, for this insightful session, definitely, because there was so much of gaps in our understanding about how these twin pandemics are running in the world, because so much of focus and attention was about learning about COVID-19 pandemic, because it emerged on the global canvas suddenly. Except for the scientists or virologists, to be more specific, we may not be familiar with the COVID science, and suddenly we were all brushing up about this coronavirus, the SARS-CoV virus, the spike proteins, and suddenly vaccines came into picture. But your session helped us understand how all these factors can be coming together, and the session title HIV and COVID-19 together, how to go together. It helped us understand what are the dynamics. So to have a little bit of interactive discussion, I just want us to understand, now in the morning panel discussion also, Dr. Tenmoli Valli said the current variant of concern, which is leading to certain parts of the world considering global shutdowns again, especially the Israel. It has already imposed 2 weeks of international travel ban. No flights are allowed to land in Israel for the 2-week duration. So how do you think, Madam said, because Tenmolivalli Madam mentioned, there is a speculation that HIV virus connection in South Africa is being speculated for the emergence of Omicron. What are your thoughts on that?
So, suggested yourself, these are all speculations. We can't, we have to always follow the evidence-based medicine, and we can't take decision based on speculations. So, the in-depth study of this virus should be made available. Then only we can conclude something. So before that speculation, I think it will create panic. So it's better not to speculate than rather than getting conclusive evidence. That's what I feel.
Okay.
So every time the new variants develop, the world is shutting down. Part of the world is shutting up, and it's a process. For past 2 years, it has become a process, and we have to wait and watch what this Omicron is giving the world.
Exactly. And when you spoke about the importance of HIV infected people continuing the treatment, and there was one slide you mentioned about treatment and disruptions of treatment. If we as medical scientists only theorizing, not fueling the speculation, okay, HIV treatment disruptions did happen during the pandemic, right?
Yeah.
Yeah. So treatment disruptions, HIV infected people subjecting themselves to treatment disruptions, the immunity being compromised. On top of that, a pandemic like COVID is added. So that kind of a mix of factors is a fertile ground for this coronavirus to emerge with the new variants. That science
that might be there. Yeah.
On that kind of fertile ground, the Omicron kind of variant emerging is not a speculation, but the origin, whether it is South Africa or South India, that is only a matter of chance who identified it first.
Correct.
So yes, that is one thing. And when I was reading yesterday about Omicron, I just wanted for the benefit of our students to learn, it is unique because the scientists are mentioning there is an evolutionary jump and 30 amino acid changes were found in the spike protein. So this is how HIV treatment disruptions lowered immunity on top of already immunocompromised people having COVID infections, mutating the virus, leading to 30 amino acid changes on a single spike protein.
Correct.
This is how we are enabling the virus to come out with stronger variants of concern. And I will just add one more point about COVID-19 vaccines reach in a continent like South Africa, because it says that only 24% were vaccinated in South Africa. And one of the reasons identified is not just the non-availability of vaccines, it's more about hesitancy, vaccine hesitancy. Why people were not able to receive this vaccine in South Africa. It is having one of the poorest vaccination rates globally. Only 24% of eligible population had been vaccinated with 1 dose of COVID vaccine. It is only 24%. The foremost reason is vaccine hesitancy. So again, when there is a vaccine available, people are not having a vaccine, leads to emergence of, again, mutational variants. Again, your session, while listening to your session, I recollected these components which could be leading to HIV, combination of factors leading to another pandemic emerging with vengeance, with variants and other kind of factors leading to double trouble, because that is how we thought how to tackle HIV and COVID-19 together. And thank you, Dr. Arvind. That's a wonderful session. It really gave me a lot of food for thought, food for my brain, actually. Thank you so much. And I know you are a busy hospital administrator and policy maker there for Chetty. So thank you so much. And we are extremely delighted. Dr. Balakrishnan from YRG Care has joined us. Hello, sir.
Thank you, Dr.
Hello, madam. Yeah. Yeah. Good afternoon. Good afternoon, everyone.
And we just have Dr. Arvind concluding his session, tackling HIV and COVID-19 together. Sir, it was a wonderful session. Arvind, would you like to say hello to sir?
Sir.
Hello. Yeah. Nice to meet you.
Yeah, thank you, sir. Looking forward for your.
Arvind, sir is like a celebrity visiting all the HIV/AIDS webinars all over the city, I guess.
Yeah. I saw his name here yesterday.
Okay.
Yes. Okay. Bye, Arvind. I'll catch up with you.
Thank you
For your valuable time. If your time permits, listen to sir's session also.
Sure.
Okay. Yeah. Bye for now. And we'll move on to the next session. And we have our next speaker, Dr. Balakrishnan from Vyarji Care. So, sir, we welcome you from Tagore Medical College. We are extremely delighted to have you with us. And from morning, we are running this live webinar for World AIDS Day 2021. And today morning, we conducted a moderated panel discussion. And we had a wonderful discussion about how to address the inequalities to end the HIV/AIDS pandemic. And we also had our HOD madam, madam can join. Balakrishnan sir is having the session. So, sir, without further delay, I would like to introduce you. And because your session is already slated at 12:30. Dr. Balakrishnan, PhD, is the currently Associate Professor, Department of Microbiology. He's also heading the Division Head of Microbiology and Quality at Vyarji Care Infectious Diseases and Laboratory, Vyarji Center for AIDS Research and Education. And he's also associated with the VHS Hospital Campus, Thermini, Chennai. Sir has been a close friend of Dr. Kannan, our Chief Officer in charge of Central Research Lab. Sir, we are so extremely thankful. In spite of your busy schedule, you accepted our invitation. We are so grateful for you taking time to address our students and interns community, postgraduates and other faculty members. We are very, very honored to have you a part of our webinar, sir. Without wasting much of your time, we would like you to go forward with your session. What is the way forward in addressing the HIV/AIDS epidemic or pandemic in today's context? And please, we welcome you once again, sir.
Yeah, thank you, madam. Yeah, I think that how much time I can take?
You can take half an hour or more than that if you wish, because we want to be mindful of your time constraints. Or
Okay. No, I don't have any problem with the time. So okay. So if I am exceeding the time, please just alert me. So accordingly, that I'll increase the speed.
Yes, sir.
Okay. So first of all, I would like to thank organizers and management for organizing this wonderful program and also invited me to this webinar. So on this special day, World AIDS Day, because for us that this is the most important day in other people. So because we exclusively work on HIV, and so apart from this, that I'm going to share my experience and what we learned so far and what is happening in HIV in the current scenario. And of my talk, if you have any question, and at the end of the talk, please come up with any kind of question. I'll be happy to discuss with you all. And I think that I can share this screen now. Yes. Yeah, my talk is going to be the present and future of HIV/AIDS. I'm the person from the organization called YRG, Center for AIDS Research and Education, YRG Care. which was initiated by Batmastri Dr. Smriti Solomon. She was our founder director, and who discovered first HIV cases in Chennai, in India, in the year 1986. And from that point, she started working in HIV, and so it is a very long history of her journey in HIV until 2015, when she was all. That is with that inspiration that we are continuing with the same spirit, our academic activities and research activities, and that's what I'm going to share some of my experience. So coming to World AIDS Day. So the World AIDS Day is the first ever global public health campaign initiated. So because we didn't have health campaign for any other disease. Okay, so it was started for HIV in the year 1988 by WHO and UNAIDS at the time. And the purpose of starting this World AIDS Day has some specific purpose, like supporting global efforts to prevent new HIV infection and increase HIV awareness and knowledge. So in general, to learn something and to educate something, so that people collectively can fight against HIV. That is the idea behind this. And not only that, and also to support for people living with HIV currently, and to remember those who lost their lives to HIV and AIDS. Okay, so these are all the multi-purpose that it was initiated. And coming to World AIDS Day, 1st December, usually people they ask why it is 1st December. Is there any reason behind that? Yes, of course. First, it is easy to remember, number one. December, before initiating this campaign, that they had a lot of discussion when to keep this World AIDS Day. Then they finally concluded December because they wanted to have this campaign in the December, because just before the long Christmas holidays, people should be educated sufficiently, or should be made the awareness among the general public, so that will be the one point that will create some prevention activities. That is the idea why they kept 1st December as a World AIDS Day. So there is a idea behind that, number one. Number two, World AIDS Day, every year they change the theme, okay, to focus something for that year, okay, for the next year. Okay, that is the idea behind that. And this year that they brought out 2021 theme, they brought up as End Inequalities, End AIDS, End Pandemics. So this is the things behind a World AIDS Day. And coming to the talk, so I'm going to give you some idea about that, what is really happening in terms of HIV and AIDS in the global scenario and in India. And in global scenario, we have around 37.7 million people infected with HIV as of 2020, and 1.5 million people they got infected newly in 2020 alone. Okay, so yeah, the incidence rate is very less when you compare with all earlier years, but it is not fast enough. Okay, number one. Number two, we lost more than 0.7 million people in 2020. Okay, so there are a lot of new infection, and half of them, half of the number that people they died due to AIDS. So this is the global scenario. And when you talk about the number, 37.7 million, and more are women than men. Okay, so I think that in the discussion that we can discuss it why it is. Number two, we should not forget that we already lost more than 36 million people for HIV. Okay, so far in the past 40 years, we lost more than 36 million people for HIV and AIDS. And out of 37.7 million people infected across the globe, majority are living in African region, more than 65%. Okay, only, so all other countries contribute only 35%. Okay, that is the reality. And if you look at the latest data from UNAIDS, and there are certain African countries, affected so much. And if you look at the HIV prevalence among general population, I'm not talking about high risk population, general population, exceeding 10 to 20%. Even there are certain countries exceeding 20%. Lesotho, Eswatini, these are all the some countries exceeding 20%, and 10 to 20%. Botswana, Zambia. So these are all the countries infected very heavily, and general population having this much infected beyond 10 to 20% is really, it's not good for the country, you know. Okay, but at the same time, if you go back to 2000, during that time, the same these African region had even much beyond 35% of HIV prevalence in the general population. Okay, so if you compare the old data, now they are doing better. Okay, 20 is not a matter when they already seen 35, more than 35%. 1/3 of the whole country was infected by HIV 20 years before. Now they are doing better, but still we should be aware that there are some countries still having more than 20% HIV prevalence. Okay, out of 37.7 million, where are we now? India is placed in third place, single country having third largest HIV infected individuals. Okay, the first place goes to South Africa, then Nigeria, then India. We are in the third place. This is the reason why that most of the clinical trial, most of the human clinical trial, it is taking place in India. If you look at a new infection and death rate, yes, of course, we keep seeing on declining phase new infection as well as death. Yes, it is coming down. You can see it's a sharp decrease. It's being observed as expected because a lot of awareness and new medications. Yes, of course, that it is as expected that things are going on. And if you look at key population, high risk population in the current period, so we have to worry about men sex with men most of the time because we didn't have men sex with men earlier. Okay, we used to worry only about sex workers and migrant workers like truck drivers in the past. But currently, we have a lot of problem with men sex with men and also drug users, injection drug users. This is the data from UNAIDS, and so the data have been divided into two, Africa and rest of the world. If you compare the data in Africa, you can see just 1% of injection drug users are the target population, and 6% with MSM. But if you compare with the rest of the world, more than 40% gay population and also 20% with injection drug users. It means that transmission, it happens and it varies from one region to other region. Okay, we know that more infection is going around only in the Africa, but at the same time, rest of the world behavior is totally different. Okay, so these are all the things that we the same kind of uh, prevalence and adult prevalence in India is being observed, and the decline, it is in parallel with the global scenario. And the same thing that when we did study in our own study, also documented the past. This is the data from 1998. Okay, so with the USAID funding that we did, and so that time we observed 1.8% prevalence in the adult in Tamil Nadu. We used that entire Tamil Nadu, 30 districts. That time it was only 30 districts that we studied, 30 districts, and the adult prevalence was 1.8% in the general population. Okay, so so that what is the total number of HIV infected individuals living in the country currently? So now we have around 2.3 million people living in the country, and at the same time we see the decline of 37% when you compare with the 2010 data. Okay, at the same time, death rate also has increased, declined more than 60%. So these are all the positive progress in our country. At the same time, there are certain states doing very bad. If you look at the data of HIV prevalence in northeastern states like Mizoram, Nagaland, Manipur, it is exceeding 2%, 1% in general population, which is alarming. Okay, so the reason why that it is very high prevalence in these states because of injection drug users are concentrated there. Okay, number one. Otherwise, that if you take that national prevalence, yeah, we are doing better, 0.22, and 20 years before it used to be 0.85. So we are doing much better, but still we need to work on. There are certain states why that they going that this much high prevalence. So that needs to be addressed. If you go by states, the state which is having the highest number of HIV infected individuals, of course, Maharashtra from the beginning, the same, they have highest HIV infected individuals in the country, followed by Andhra Pradesh and Karnataka. Then HIV subtype. Subtype C is, but here this is from our own study. We documented 100% of the strains circulating in southern India is subtype C. If you go to north, I think it will be somewhere around 95%, and remaining 5% are recombinant strains because it is closer to the northeastern states, so that drug trafficking with the borders from Burma, Myanmar, so you'll have some recombinant strains, mixer will be there. But otherwise that we have the predominant strain is subtype C. Subtype C is most virulent and more transmissible than subtype B, which is most common in Western countries. Okay, so this is the reason why that we have more problem with the HIV than Western countries. So subtype B comparatively less transmittable. Okay, so I told you that MSM and injection drug users are the real target population in the current scenario. And this is the study we conducted in the recent period, and we not only it is across the country. Okay, so if you look at the data among MSM, HIV prevalence is about 7% average, and there are some places it is exceeding 10%. Okay, so MSM is a real problem in the south, in fact. And this is the study within Tamil Nadu, and there are certain cities, certain place, they have beyond 15%, particularly Nilgiris, Ramnad, Tuticorin, Tirunelveli. They have more than 15% HIV prevalence in MSM. Yeah, thanks to the IPC 377 ban. So what is the IPC 377? IPC 377 is nothing but it is the law against homosexuality. Okay, it was this IPC 377 was banned on 6th September 2018, and why we have to be happy about that? Okay, so why? Because when you are allowed to say that you are homosexual. Okay, when you are allowed to say that you are homosexual, so you will come up. Okay, otherwise that you will be penalized. Okay, before 6th September, if you say you are homosexual, you'll be arrested as per the law. But now it is not. Okay, so it helps a lot in terms of prevention, because people will have health-seeking behavior. Health-seeking behavior comes, then they go to healthcare centers and they get it tested regularly and go for the medication, so that also will help in terms of prevention and the long term. So if you look into HIV prevalence among injection drug users, and we did a very larger studies in the country involving different states, and you can see that very high HIV burden in injection drug users in this population in northeastern states. Okay, so the HIV prevalence is about 18% in injection drug users in these places. 18%. So unfortunately, most of the injection drug users are co-infected with HIV. Co-infected with HIV. More than 80% prevalence of co-infection, HIV and hepatitis C virus. Okay, so why it is so bad? Because people, those who are infected with HIV, will go for the medication. Okay, HIV medication. When they go for the HIV medication, and they'll have a lot of problem because already liver is not in control, and when you add up HIV medications, it will become severe. So the tolerance, the serious adverse events and side effects will be more with co-infected cases. So that is the one thing. On the other hand, the HIV co-infected in India, the prevalence of hepatitis C virus is genotype 3. The most of the strain circulating in northeastern states is genotype 3. What is the special with genotype 3? This is the genotype which has got the characteristic of faster rate of fibrosis progression and also causing hepatocellular carcinoma. So this is the reason why it is highly dangerous situation when people are infected with HIV and HIV genotype 3. This is the study that what we conducted in Chennai, because like northeastern states, in Chennai, we have certain area where injection drug users are concentrated, like Rayapuram, Kasimedu. These are all the places where more injection drug users are there. Okay, so we studied in the year 2007 and 2016. When you compare the data, you can see that very high prevalence. I request audience, if you mute the mic, I think it will be good. Yeah. So if you look at the data, if you compare the data between 2007 and 2016, you can see that the large variation. Okay, large difference. So it means we are doing better. Because why? Because there are so many NGOs, including YRG Care, working on in the field to prevent HIV further and further, and we brought down to less than 15%. So this is the global data which says three things. Number one, people living with HIV who know their status, the more than 15% of 14%, 16% of the people, they don't know the status. They are infected. They don't know the status. Okay, so which is very dangerous because they keep on spreading the infection further. Number one. Okay, so people, those who are knowing the status, but they are taking only 73% medication. Okay, so treatment, because current treatment guideline clearly says that people are, once you know you are positive, you take therapy. It means the same day therapy is recommended as per the guidelines. Most of the international guidelines clearly say that you go for the medication immediately. Okay, so but most of the people, they are not taking the medication. Okay, which is very dangerous. Other thing is that those who are taking medication, they are not suppressing the virus 100%. Nearly 40% of the people, more than 40% of the people, they are really not doing better. So it means they are likely to develop drug resistance for a period of time, which is very dangerous. Even not only their health will get deteriorated, and also they will transmit drug resistant strains to other partners. That is the thing. So we almost crossed for 40 years from the first cases reported in Los Angeles, and so the standard questions still there. Are we having HIV cure and HIV vaccine? Our answer should be no. Why? Because it's a slow viral disease, and we need to understand both viral and host factors. We need to understand it better, because the virus which is being circulated in Europe, circulated in US, circulated in India and other countries, African region, is not the same. Different subtypes, different variety. Okay, so we first of all we need to understand the virus fully. Number one. Number two, similarly, the host factors also play a major role. Okay, the genetic makeup in Africa, in Asia, in America, so it's totally it's highly variable. Okay, we can't just generalize the things. So first of all, we need to understand everything in terms of virus and host genetic factors. When we completely understand both, then only we'll be able to have some solution in terms of cure and vaccine. Okay, so though it is taking time, still that it is workable. Yeah, almost there are a lot of development happens in terms of understanding the pathogenesis, understanding disease progressions, and developing medications. So we have a lot of excellent drugs available in hand. Which I am going to speak speak a little later. Yeah. So with regard to viral factors, I'll show you. Yeah, so this is the data what we generated from our study, and this also clearly shows that even viral factors viral factors, even small variation, which will have a lot of impact on the infected person. You, in terms of viral load, in terms of CD4 count, it will have. So, if that is the case, so we need to be very clear about the host factors and viral factors completely before getting some fruitful information on cure and vaccine. So here, that what I'm trying to say, when the person is infected, this is more than 90% of the people, they develop into typical progressors. Most commonly, they develop, if they are untreated, they develop AIDS defining illness. But there are some people, less than 10% of the people, they rapid progressors. So they progress into a AIDS condition within 2 to 3 years. Okay, this is the very important subject, long-term non-progressors. Even after 15 years, 20 years, they don't develop any complications. They don't develop even signs and symptoms of AIDS defining illness. Okay, but unfortunately, we have this kind of population, less than 1%, least. We have two other very interesting subjects, allied controllers. So this is most important. People, they are infected. If you test them antibody positive, then if you go for the further test like viral load will be very low, or most of the time undetected, but still they are infected. They are called allied controllers. We have other interesting group, that is exposed and infected. Better than these people. They are exposed, constantly exposed, but they don't acquire the infection. It is because of their genetic makeup. So these are all the three different interesting groups: long-term non-progressors, allied controllers, exposed and infected. These are all the three important groups. They are the tool, study subjects for the future research. The researchers like us, they hunt for these three group of people, so that we can explore more and more to reach the goal of HIV cure and HIV vaccine. So this is the study we conducted in OIRG, and so the study conveys the one thing. So how that long-term non-progressors, LTNP, how really control HIV? Yeah, so we have some specific mRNAs in our host, which controls replication of HIV, which can regulate host proteins that HIV uses of our own replication. So which controls HIV replication and lower the HIV viral load in long-term non-progressors. So this is, we have other evidence that also documented that people, HIV infected individuals, those who are long-term non-progressors, also having the other characteristic of having broadly neutralizing antibody response. They have broadly neutralizing antibody response. It means, so they'll be able to neutralize the viruses of even small variant. Okay, so that these are all the reason why they are able to continue to be a long-term non-progressors. These are all the reasons. So we need to understand the mechanism behind it. Then it will be easy for us to come to the conclusion for HIV cure and vaccine, very particularly vaccine. Yes, of course, that we are still continuing to search for HIV cure, but we keep seeing a lot of reports in social media, and there are so many people got the HIV cure. But in the reality, only these four are cured so far as of today. Berlin patient, London patient, both are cured, declared scientifically, but these two patients undergone stem cell transplantation in the past. Okay, number one. Number two, these two patients, San Francisco patient and Speranza patient, This is the patient from Argentina. This is the patient from California. So these two patients are elite controllers. What I showed you, elite controllers. So these people, without any medication, without any stem cell transplantation, they cleared the virus from the body. They eliminated the virus totally from the body just by their own immune system, just because they are elite controllers. It means there are some elite controllers over a period of time, they come away from the HIV infection. Okay, so as of today, because this Speranza patient was declared officially only 2 weeks before. So as of today, we have only 4 patients so far documented that they are free of HIV. Yes. So these are all the 2 patients who undergone stem cell transplantation. So why we call Berlin patient, London patient, San Francisco patient? Because patient initially they don't come to media. I mean, they don't want to show their identity. But over a period of time, they come up. Okay, now we know that who is Berlin patient, who is London patient. So these are all the patients who declared they are HIV cured. So these 2 patients undergone, unfortunately, they had cancers. Both patients, they had cancer. So because that is the reason why they went for stem cell transplantation. So when they went for the transplantation, so their oncologists were searching for donor, those are having CCR5 delta 32 mutation. Okay, you know CCR5 is a co-receptor for HIV infection. Okay, when you have the donor with 32 mutation, so once you transplant that particular stem cell, so that will eliminate the virus from the body, because virus cannot replicate further. That is the idea behind that. So these are the 2 patients I mentioned, San Francisco and Speranza patient. And still this lady has not revealed her identity, but of course this lady has revealed her identity recently. And so these 2 people, recently they declared HIV cured, and after scanning more than billion of cells from the body. So, okay, so there is no trace of HIV genome anywhere in the body. Okay. Okay, apart from this, that anything else we have seen fruitfully? Yes, of course, I would say therapy, antiretroviral therapy. Antiretroviral therapy, it's really played a major role in terms of R&D. Okay, so we used to see that people taking lots of pills for HIV treatment. Okay, so now you see just a single pill a day, and also in the future, near future, of course that already Western countries they started long-acting injectable. You take just to give long-acting injectable drug, then 1 month or 2 months, no need to worry. Again, take one injection. Just 1 or 2 months, you don't need to worry about any medication for HIV. So this kind of development is happening. These are all the recent development. So which I am going to speak much on this. Yes, of course, we have a lot of excellent drugs available currently. Whatever the drugs which we are using it, which is very efficient or less toxic and affordable. Affordability is the question, because 20 years before, for each person, each patient, you have to spend at least 25,000 rupees per month. But now, just 700 rupees, less than 700 rupees per month, per head. Okay, so affordability is also the question. So now we have excellent drug which is less toxic and affordable. And when to start, it is the most important thing that we learned in the last 20 years, because initially we never know. So what should be the cutoff when patient has to initiate their HIV medication, which we never know. I tell you that what will happen. Okay, very first HIV drug, it was started in the year 1987. It's a monotherapy, zidovudine. Then it didn't work as a single therapy. We added a second drug, dual therapy. Yes, it worked a little bit. After some time, it developed resistance. Then we made it as triple combination therapy, cocktail. So it worked very well, and still we are continuing as of today. Okay. Only thing is that we kept on changing the drug. Triple combination therapy is standard, but we changed the molecule. Sometimes we have been using nevirapine. Then we thought nevirapine is not good for health. You throw it out. Then stavudine, not good for mitochondrial toxicity. Throw it out. So we changed only a molecule, but we continue to use triple therapy as of today. This is how that we take the combination therapy, combined therapy from the different drugs. These are all the different drugs. This is how that we over a period of time that we remove the drugs from the list. Okay, based on their long-term toxicities. Okay, so because even up to phase 4 trial, we never know what is the long-term side effects. Okay, once you introduce into the market, then only you will understand. In the real world experience will be there. So how exactly it is working with the patient. Okay, so very particularly long-term side effects. Yes, of course, that once people on ART, they do very well. They suppress the virus, they preserve the immune system, that whatever the quality of life similar to uninfected individuals. But at the same time, once you stop the medication, ART medication, the virus will rebound. Okay, so it means it is just like diabetes. The moment that you stop the therapy, so virus will come back. So it's a chronic disease and long-term management with the medication. I told you that when to start medication. This was the research question before 2008. So when to start the therapy. So people, they researched in various level with the different population, and because people, they thought that we should not jump into ARV medication immediately. That might affect the people, those who are taking the medicine. But actually it is other way around. So we learned every stage that we changed the cutoff, 200 to 250, 250 to 350, 350 to 500, and treat all policy. Today, what we do, initiate the medicine immediately on the same day policy. It means even don't postpone a single day, so you'll be losing something if you delay it. So that kind of benefit is there if you take the medication immediately. Yes, we have the HPTN 052 and START. These are all the two very large multi-centric, multi-country, multinational clinical trials that conducted. It was sponsored by NIH, and I am proud to say that we were part of these two trials, and I was involved in these studies. And these two clinical trials brought out very important information on when to start. So this is the trial shown that you start the treatment immediately. Don't waste your time. Immediately start the therapy, number one. So it gives you individual benefit, so that it will save the life, and also it will prevent a lot of complications over a period of time when he or she is on the medication, number one. Number two, this also offers public health benefits. How? When people infected with HIV, they have lower viral load in their blood circulation. They'll be unable to transmit the virus to the sexual partner or other injection partner. Okay, so it means undetectable equivalent to untransmittable. It means when you treat the person, the viral load will become undetectable. When viral load is undetectable, he or she cannot transmit the virus to the partner. So treatment has become prevention method now. Okay, so this we came to know only very recently. Okay, so I told you HPTN 052 clinical trial. It actually changed all the guideline, international guideline, US guideline, WHO guideline, all local country guideline, including NACO. Okay, so this is the reason why that today we have the policy same day treatment. Okay, so this is our own study that we conducted across the country involving MSM and injection drug users with very large cohort, and that also conveyed the same thing. What? Prevalence of viremia was more strongly correlated with HIV incidence. It means people with very high viral load, when we have high viral load, when they are not treated. Okay, so they are likely to, people with high viral load likely to transmit the infection to the partners. Okay, so this is the message that we got it from this study also. Okay, so apart from that, we have PrEP now, pre-exposure prophylaxis. Okay, condom used to be a prevention, the best method for HIV prevention. Okay, from the beginning. But in the year 2013, WHO introduced the guideline, released the guideline that take PrEP medication, that is two-drug combination, emcitabine and tenofovir. So it is brand name Truvada. Truvada is so popular in Western countries now because people, they use pills rather than using the condom. Okay, so why? Because so the problem with this particular strategy is that people has to take everyday pill. Every day they have to take, continuously they have to take a pill, and it is also expensive. In US it is costing around $2,300 per bottle. Bottle will have 30 tablets. Okay, but in India it is quite cheap, 1,900 for 1 month. Okay, but still people they don't prefer because it is expensive. Number one. Number two, adherence. Sometimes people, they may forget to take the medicine. Okay, this is the reason why recently in 2019 WHO brought out other guideline saying that 211 concept. What is that? That is otherwise called disco dosing, party PrEP. It means just before taking the risk behavior, take 2 pills. Then after the risk, you take 2 pills. That's enough. That will serve the purpose. 99.9% it will serve the purpose. Prevention is assured. So why to take throughout the year? Okay, so this is becoming popular now. Okay, so how that future treatment is going to be? So I told you that how we evolved. Initially we used a single drug, then 2, then 3. The 3 drugs works well, and now we are in the situation reducing the number of drugs now. Very soon that now 3 drugs concept still we are using with the 3 important combination, that is TLD, tenofovir, lamivudine and dolutegravir, and very soon we are going to throw out tenofovir, so that only 2 drugs will be using. Already some countries already they pass the guideline with the true drug concept, and very soon it is going to be available everywhere. Everybody is going to adopt that. Then widening dose intervals. What is that? So instead of taking, now what we are doing, every day take a pill. Okay. So just once in a month, once in 2 months, that is enough. That's what that recent clinical trial concluded. So not to take everyday medicine. And so the same long acting injectables are going to be used for this kind of monthly once in 2 months concept. Okay. Then there are certain formulations like implantable. Implantable means you take the medication, it will be in the medicines will be in the cassette that will be implanted in the body. That is going to release the medicine slowly for several months, several years, so that once you implant, you don't need to worry for several years. Okay, that is going to come up. It is at the experimental stage now. Then using broadly neutralizing antibody. Yes, it is possible. People are working on it. Still, it is in the research. What are the other approaches people they adopted for HIV cure? Yes, drug intensification. What does it mean? Instead of 3 drugs, give 2 more additional drugs so that we can kill HIV or eliminate the virus from the body. But unfortunately, it was not worked. Okay, it failed. In fact, it failed. And if you take medicine like this, and your vital organ will go away. Okay, it will get damaged. So the even irreversible damage. So that is the things that we learned from this strategy. Hit hard. It is not working. Then hit early. So the person, those who are getting infected, don't wait. Even the moment that you see, even within a week or within a month, you go for the medication, so that whether that will solve the problem of cure. So that also did not work out in many studies, but at the same time, there are some studies is being even still being continued. We'll know after some time. So these are all the different approaches. I told you this, our Berlin patient and London patient, they adopted this stem cell transplantation, but this works actually, but this cannot be replicated everywhere because it is highly intensive and highly expensive one, and also it is dangerous. It cannot be done easily. These are all the 2 people they went for transplantation for cancer therapy, not for HIV. Okay, so this cannot be replicated everywhere. At the same time, we can't find a donor always with CCR5 delta 32 deletion. Okay, which is not feasible, and for the practicality. Number 1. Number 2, that we have the other option called gene editing. It is something like using the molecular scissor, cut away the provirus which has been integrated into the host genome, cut away the gene. So it is in the experimental stage. We have to wait and watch how it is going to work out. Then shock and kill. It is it was very interesting strategy, and last several years, more than 10 years, that people were conducting the clinical trial. Shock and kill. What is that? It is something like irritate the virus to come out of the cell. Okay, when viruses are coming out, you kill the virus with using the ART. That is the concept. It means researchers, they thought that whatever the virus which is in the latency period, so once you make the virus to come out, there will be all the virus will come out. Actually, it is not. What happened really? So that they retained the copy of the viral genome in the host genome, and they started sending only replica of that. So it's a total failure. So they spend lot using this concept, but finally it didn't work out. Then this is the best strategy what people use. They promote it right now, but we don't have any results so far, but it looks promising because this is the very simple concept. just opposite to this. Instead of doing shock and kill, block and lock. So already the virus is in the latency stage. The pro-virus inserted into the host genome, it is in the dormant stage. You make it permanently locked. So don't allow the virus to reactivate. Okay, when you, there are some molecules, there are some drugs which make the virus to sleep longer. So that that will be enough. That is called functional cure. So currently we don't have anything. I think something is better than nothing. So block and lock seems to be feasible, but we need to wait. Yes, this is a block and lock approach. Once the cells go into deep latency, and there'll be unlikely that we'll see the viral rebound. Okay, coming to vaccine. Yeah, we have a lot of roadblocks everywhere, and the HIV virus, it mutates. I told you in the beginning that virus replicates like anything, and inherently that mutation, it happens in every replication. So it changes its outer layer, and so we are unable to develop vaccine for HIV even after 40 years. Okay, though we have vaccine for COVID-19 less than a year, but this is the virus. HIV is just 1/3 of COVID-19 virus. Okay, it is 1/3 in genomics if you look at. Okay, but still we are unable to, both are RNA virus, but still we are unable to have vaccine because it mutates very fast. And at the same time, no good animal model for HIV, because we have to depend upon higher animals like monkeys, and most of the time human. Okay, so that there are ethical concerns behind that. So, and also long-term follow-up visits. Since being a slow viral disease, we can't make the clinical trials or studies within shorter period. So we need to wait for a longer period to come out with some fruitful results. Okay, this is the slide that which shows the timeline for vaccine efficacy trial, because several billions dollars that have been spent on vaccine R&D, and clinical trials throughout the world, but unfortunately, no clinical trials as of today came up with fruitful results. But of course, in the year 2013, and there was one trial that allowed, first ever reported some protection at least. So it was RV144 trial. It is also known as Thai trial. It was conducted in Thailand. So it has the protection of 32% protection. But at the same time, unfortunately, this is not sufficient enough for us to go for the vaccine. At least we need 50%, more than 50%. Okay, so then based on this concept and other trial called HBTN 702, the same have been improvised and implemented. That trial also failed. This failure was announced just 2 or 3 months before. Okay, that also failed. And we have other trial running, that is HBTN 705. We need to wait for some more years to see the result. Yes, this is the trial which has that the 32% protection efficacy. And what is that? So this is nothing but viral vector, canary pox viral vector vaccine along with genetically engineered GP120. So it's a mixed vaccine. So it has some potency, but it doesn't give full protection. Maybe that people they have to work in and around of this to improvise the efficacy. Let's see. Yeah, before ending the session, that I would like to convey the message that, so now that AIDS Bill 2017 is in place, Okay, it's a legal requirement. So I know that there are several hospitals and healthcare settings, including laboratories. They do HIV testing without informed consent. Okay, which is illegal. Okay, written informed consent from the person is mandatory. Okay, so please spread this message everywhere, and so it also helps the people and also helps the healthcare workers protect from the law. Yeah, to conclude, yeah, tremendous R&D happened, particularly understanding pathogenesis and HIV medications. And in spite of excellent drugs available currently, HIV patients still persist in the body and require massive effort to attain cure and vaccine. And also, we should be thankful to the infrastructure what we developed for HIV research, because using this infrastructure only, we were able to handle the COVID-19 efficiently throughout the world. Okay, not only in terms of developing the vaccine and conducting the clinical trials, and also for the diagnostics and also for the clinical management. Thank you all. Yeah, much accomplished. We have to do much more. Thank you.
Thank you, sir. That was like an entire encyclopedia of HIV evolutionary history, as well as what is the future directions we can actually look forward and keep track of, because the implantable injections you have told us, the stem cell therapies that are in practice currently, and what kind of results we can expect, and the case studies you have revealed about how after tracking so many cells, there is no evidence of HIV genome in certain case studies. And the work you are involved with, especially the theme of today's World AIDS Day 2021 is ending inequalities, ending HIV AIDS, and ending pandemics. And you have your research work, the institution of YRG care research work, you have focused on especially high-risk group populations like injection drug users, MSM, and vulnerable population groups. Your research work has been shared with us, and especially the data you showed state-wise, district-wise, and regional prevalence data and all that. It has been really very useful for public health scientists like us, the Department of Community Medicine, as well as Microbiology Department. Thank you so much. In spite of your busy schedule, appearing in a lot of webinars today, I understand it has been tiresome for you since morning, but thank you so much, sir. It's very difficult for us to get access to this data, because published data only we can access, and there are so many limitations. But coming from an expert from YRG Care and listening to your session has been very much thought-provoking. So I have one or two questions which we are discussing along with my postgraduates. Sir, how can we build institutional partnerships? See, you are aware, like Dr. Kannan sir is a great support to us, being an immunologist, virologist. Recently, in the evolution of pandemic, we have submitted one proposal to one grant application. Unfortunately, we did not get selected. There are so many limitations for that. We wanted some DSIR certificate, which is mandatory for certain fund seeking from ICMR and other portals. But I just want to seek your guidance in this platform. What kind of institutional partnerships can we leverage with YRG Care in an academic institution like ours, like Tagore Medical College, with a decade of service to the community we are doing here? Is there any scope of us to go forward and do some very meaningful research with HIV and vulnerable populations? We serve migrants through our outreach camps. We serve LGBTQ populations through our work. Is there any scope, sir?
Yeah, definitely. I think that people like us will be happy to have this kind of collaboration with other institutions to expand their capacity, because usually people like us, we need more kind of target population, okay, for any kind of research. Okay, so this is one thing. Number two, you told me that there are some constraints related to DSR certification. Yes, of course, it is true. When you are private, if you are a government institution, you don't no need to have anything. But when you are in private, you have to. But at the same time, still it is possible even without DSR certification that you can still continue to get the funding, because when you go for the collaborative approach, suppose you are collaborating with YRG. Okay, so still you can be listed as a site. We can receive the fund. We can release the fund from directly from us to your institution, which is possible, which is permitted by ICMR. Okay, so not only ICMR, even other funding agencies like SERB, DST, DABT, they also accept it. So number one. Number two, yeah, of course, so that we have to find a way how we can collaborate. Even we discussed earlier with Dr. Kannan also. So I think we'll find a way.
Thank
we
you
can
so
do
much.
it. Yeah.
Because right now, Kannan sir and me, we are also in Central Research Lab. I'm research coordinator, sir is officer in charge. Immediately, we'll follow up on your promise and we will make it happen. January 2022 is around the corner. We would definitely like to work with you, sir, the YRG Care, because when I was doing my fellowship in 2007 with the Government Hospital of Thoracic Medicine, I visited YRG Care. And as part of our fellowship with CDC Atlanta, the ITech fellowship in HIV TB, and your faculty used to come and take classes for us. We came for on-site visits to YRG Care multiple times. I visited VHS campus also, and it's been my dream to work with YRG. And if with this encouragement you just told us, we would like a partnership with YRG and Tagore Medical College, and we will work with you, sir.
In fact, I was one of the faculty, but I don't know whether that I handled your batch.
You might have, and I remember for one conference, I traveled with other sir who was, we both traveled for one conference, international conference, and we were in the airport for a long time. We traveled back together.
Okay.
So definitely, sir, we look forward and we will take this partnership thing serious, and we'll come and meet you, and definitely we'll formalize this association so that because we are, as I said, we are working with LGBTQ and construction site workers. There is so much of potential for us to collaborate, sir.
Yeah, definitely, with pleasure. Yeah, we'll do that.
Thank you so much, sir. And I would now like to thank formally for your time. And this session has been, as I said, an eye-opener, and thank you so much for your valuable insights, sir.
Yeah, thank you so much. Thank you so much. Yeah.
Now we'll move on to the next part of our webinar. We, as I said, we also have announced post-presentation submissions from our medical undergraduates, interns, and postgraduates. And we have received a tremendous response, and we shortlisted the most insightful and best posters, which were assembled by my postgraduates. Dr. Niveda has put together the entire shortlisted bunch of posters, and I would request Dr. Kannan sir to share the screen and present the shortlisted posters received for the World AIDS Day webinar. This is the postgraduate category. Dr. Niveda's Paving a Way Forward for AIDS-Free World. This is by another postgraduate, Elimination of Mother-to-Child Transmission of HIV in India by Dr. Kavita. And the other postgraduate poster was World AIDS Day, Measures Taken to Tackle Inequalities, fitting into the theme, once again, Human Rights for All. Morning session also we discussed the human rights approach is the best approach to address inequalities currently battling the pandemic. So we have to end inequalities to end AIDS and pandemic. These are the three posters received in the postgraduate category, and these are all in the interns category. So sir can scroll down. A bunch of posters in various themes: HIV, TB, vaccines, ongoing trials, inequalities, and once again, addressing inequalities. Yes, these are all the interns group of posters. Thank you, dear students, both postgraduates and interns, for your tremendous response to the call for submission of posters. November 30th was the last date. And this morning we shortlisted from the entire group of submissions. These are the shortlisted posters. Thank you so much. We appreciate your participation under different categories. Now I request the showcasing of posters under undergraduate category. Students have formed different teams, a team of 5-6 members. To be honest, the undergraduate posters were better than the interns, to be honest. I always like to be honest. So the undergraduate submissions were more creative, best laid out posters in landscape format and put together, because there were more team members. So it always proves that more minds, more creativity flow was there. So, sir, requesting you to showcase the undergraduate category of poster submissions. Slideshow, please. Though we could not accommodate a session on HIV vaccine, this is again ending inequalities. This is an interesting creative layout. Dr. Suganya addressed this 2021-26 HIV AIDS vaccine. This is a beautiful poster, definitely. Next. Next, sir. And vaccines, the aid to end AIDS, a novel dimension. Very nice poster, well laid out. Good efforts by the team led by Surya Prabhu. Next, sir. Tagore Medical College and Hospital World AIDS Day. The title should always be the topic, not the college. The TB disease and HIV. This is very nicely laid out, but the only drawback is the title should be the title of the poster. Next. Again, the same issue, World AIDS Day, AIDS and COVID-19. They try to address the twin pandemics. Next. HIV, COVID-19, twin pandemics again. This is an interesting way of addressing HIV vaccines. This is our, I think, the interns posters. Yes. Okay, fine. These are all the group of posters. Yes, thank you, sir. Can we request Shivaguru to mute, please? Dr. Shivaguru, mute.
Yes.
Shivaguru can mute yourself.
Oh, I'm sorry.
So we are going to announce the prizes. So after going through the list of poster submissions under different categories, we are now going to announce the prizes. Under interns category, Dr. Daphina Blesleen is awarded the first prize, and Dr. Ari Abhirami is awarded the second prize. Dr. Daphina addressed inequalities through her poster submission, and Dr. Abhirami addressed vaccine for HIV through her poster. We congratulate both the interns for submissions, but you can always do the better job, ma'am. You have seen the selection of posters in submissions in the shortlisted category. Please do your best efforts going forward. Once again, congratulations for submissions as well as winning. Coming to the undergraduate category, as we said, we have got more better poster submissions, and we decided that it's only better that the better efforts has to be appreciated and not limit to only 3 individuals. So we gave multiple teams the privilege of winning the first prize. So 2 teams are winning the first prize. The first prize goes to Barani as well as Fayaz Muhammad teams. They have put in the posters addressing the theme of this year, inequalities theme. Congratulations, teams. You have done the best job in the creation as well as addressing the theme head on. Congratulations once again. The second prize goes to the, again, 2 teams, Vaishnavi MN team and Surya Prabhu MN team. They win the second prize for talking about HIV vaccine trials. Definitely there is lagging in vaccine trials. That itself shows how challenging it is to talk about HIV vaccine development. Scientists are breaking their heads, brains, whatnot, but we are definitely going to reach that stage. If at all that is possible, nothing is impossible. So congratulations, Vaishnavi Surya Prabhu teams for submission of posters fitting into HIV vaccines category. The third prize goes to two teams once again, Harini S and team, Nityavarshini MN team for submission of posters under categories HIV tuberculosis, HIV COVID-19. Thank you, students, for submitting all these wonderful posters. I appreciate your attempts, and as I said, undergraduate category poster submissions are far better than interns. Interns have to amp up their efforts. Do not do passive submissions. Be creative. And through this platform, I once again congratulate the efforts of all the students of Tagore Medical College for submitting World AIDS Day 2021 poster submissions. Good efforts. You can do better going forward, especially sincere efforts and were taken by postgraduates because they participated in a competition, not just submission. They presented to a panel headed by Dr. Premlata, Professor, Department of Microbiology, and she has allotted on the spot her time, valuable time in spite of her busy schedule, graded the performance, presentations, layout, poster development, guided by the faculty of the department, Dr. Shivaguru, Dr. Vikram, Dr. Karthik, and co-PGs, Dr. Vinod Raja, and others who guided both co-PGs as well as students in poster development. I thank everyone's efforts which went into poster development. Once again, the department is at forefront in conducting this webinar. Thank you, everyone. Thank you, team. And I appreciate the efforts taken by postgraduates of my department in presenting. This is how you develop your presentation communication skills. Thank once again the Department of Microbiology for judging their presentation skills, giving a scorecard and picking out the winners in the first order. The first prize goes to Dr. Niveda for presenting her poster on addressing the inequalities. There was a very narrow band of winners eliminating the second runner-up, Dr. V. Kavita, whose presentation is on PPTCT, that is prevention of parent-to-child transmission of HIV. All of you remember I worked in that program for almost 3.5 years, touring Maharashtra, Andhra Pradesh, now divided into Andhra and Telangana, as well as Tamil Nadu for 3.5 years before joining Tagore. Now I'm completing 10 years. The third prize goes to Dr. Kirtana. Again, her poster addressed inequalities through human rights approach. So once again, congratulating all my postgraduates for taking immense efforts in middle of busy schedule. We are doing back-to-back webinars, training programs. I appreciate your immense involvement, engagement in the learning process. PG life is tough, but it is essential that you improve your standards of participation in all the competitions. Congratulations once again. I thank all the participants once again for their efforts to participate in World AIDS Day webinar put together by two departments working closely, Department of Community Medicine, Department of Microbiology. Sincerely thank once again Dr. Tenmoli Valli Madam for her immense support, unconditional support, to be honest. She said yes from the day one. Go ahead. We went ahead. Thank you, Madam, once again. And my guide and mentor, Dr. Kannan sir, without whose support, all these programs will not be materializing, from the IT support, design support, every support. If I'm not mentioning something, it's only for lack of time. Thank you so much, sir. And my PGs, always my strength for everything. I depend on them. Thank you so much, postgraduate students. Once again, I would like to thank Mala Madam. She responded appreciating our efforts. Thank you, Madam, for your encouragement. We will do better as a department going forward. And we thank Secretary Sir, Manikantan Sir, for his constant encouragement and positive appreciation whenever we do something. He's the first one to appreciate us. And all the college support for internet support and other facilities with which we conduct these webinars uninterrupted. Thank you so much, everyone in the college and outside the college for helping us, especially Mahesh sir from the stores for printing out the pamphlets to deliver to all the departments, intimating them. Thank you all once again for this wonderful support. And we hope we will reach out to you once again for another public health day of importance and share the knowledge from wide variety of experts. And I would like to thank Dr. Suganya, Dr. Arvind, and Dr. Balakrishnan sir for joining us in this webinar. The other two speakers whom we mentioned in the program, one of them fell sick because of the floods and relief camps they were organizing. The other program manager is part of the HIV/AIDS program meeting happening in the state's 8 controlled societies. So we would try to bring them some other time to share their insights. Thank you all so much. With this, we conclude the webinar today, and we'll reach out with another program very soon. Thank you all.